Yeah, now it's live.
Varsha, are we live?
Oh, Arnab, can you mute everybody?
Yes, sir. Sir, we are live now.
Yeah. Okay. Dr. Anaita, can you? Yeah, okay, that's perfect. So, good afternoon, everyone. I, Dr. Shah, Senior Pediatric Surgeon, on behalf of SRCC Children's Hospital managed by Narayan Health, welcome all the participants to today's very interesting talks by three speakers. The details will be given by Dr. Shah, who is the moderator for today's session and is a pediatric orthopedic surgeon. So as you know, we are passing through COVID pandemic, but at the same time, we must say that at SRCC, we have almost running like pre-COVID time, with all OPDs are functioning, our operating rooms are functioning, and those who have seen SRCC Children's Hospital, that we have adequate space, yes, I mean adequate space in the OPD as well as in the indoor. So there is a natural distancing between the people, and those who have not seen, we will welcome you to visit SRCC Children's Hospital whenever it allows you. With that few words, I will tell Dr. Avisha to take over with the proceedings of the day.
Thank you, Rasik sir. Hello, good afternoon, everyone. Welcome to today's masterclass for family physicians. Just some housekeeping rules before we start. Everyone other than the speaker, kindly keep yourselves muted, and also you can keep your video off so that you all can see the speaker speaking. And whatever questions you have, kindly put it in the chat box, and we'll try and answer as many questions we can at the end of each speaker's talk. Welcome again, everyone. And today we have an amazing faculty and three really complex and eye-opening talks. We'll begin with Dr. Anaita Hegde, who is a senior neurologist and has a vast experience of more than 40 years in pediatric neurosciences. She's also one of the founders of the Pediatric Rural Neurosciences Program in Maharashtra, and she's a part and lead in multiple multidisciplinary clinics for all neuromuscular diseases in SRCC as well. And she's going to talk on an important topic about the management of headache in children. So I again welcome Dr. Anaita, and if you can unmute and start your talk. You're muted, ma'am. If you can just unmute yourself.
Okay. Is that better? Can you hear me?
Yes.
Okay. Good afternoon, everyone. Thank you, Avi. Thank you, Rasik. I think today we're going to be covering a topic. It sounds very simple and it sounds very, I don't know whether it's not that interesting, but it's a very, very common problem we see in children. And I think we need to, what we're going to cover today is basically headache, a little bit on stats, classification. What are secondary headaches, which are the ones we don't want to miss as physicians, primary headaches, migraine variants, what are the investigations, how aggressive should we be, when to stop, when to go, and then the treatment of these headaches, acute as well as prophylactic treatment. So headache in children is a very common complaint, particularly in children and young adolescents. It's the most common cause of migraine is the most common cause of recurrent headache and comes in the top 10 complaints of all time children's disorders. It's very frequently ignored by parents and teachers, and there are lovely studies to show how teachers have totally ignored children in the class who complain of headaches And as a result, you end up losing school days, social interaction, academics goes down, and eventually self-esteem. And estimated to have, so it's very essential for us to do a thorough yet quick evaluation to identify not just those who need to be investigated further, but also to improve the quality of the life of the child. So from epidemiology point, 37 to 51% of children 7 years have complained of a headache. That's not small. 50% of children have told you they've had a headache sometime or the other. And 57 to 82% of children by 15 years. I don't think there are many conditions which can give you an 82% incidence risk in the pediatric age group. You see that the graph is here of these migraine take 75% of the cases, particularly those referred to us for a neurological consult. And you can see the dark brown is the blue boys and the light red, the red is the girls. And while in the younger ages, the girls and boys are equal in distribution, it is at adolescent that there is this huge peak which comes in the girls, which is presumed to be due to menstruation as well as stress and anxiety. So what is the burden of this disease? Again, you think it's just a headache. That's how we put it. But living with chronic pain is no fun. Associated behavior concerns, they become irritable, cranky, frustrated, ADHD symptoms come out. Intra-family dynamics go for a toss. Siblings can't understand why this one is moaning and groaning all the time and complaining. Parents tend to get tired. So sibling problem, parent-sibling problem. School absences, you tend to drop out of classes, miss classes, go home half day, and thus the academics takes a hit at home as well as in school. The worst part is the social dropout. Kids stop calling you for events and activities. You can't participate in sporting activities, so physical limitation, and eventually this leads to a low self-esteem. So what's the present classification? This is the new classification of pediatric headache, not just headache, by the International League of Headache. And it's migraine, tension type, trigeminal neuralgia, and other primary and primary. And secondary is either secondary to trauma, injury, vascular pathologies, non-vascular pathologies, substance abuse, infections, bleeding or hemostatic abnormalities, cranium, eyes, ears, nose, throat, teeth, anything in the orofacial region which is there, or other, and most important, not to be missed, is psychiatric disorders. Another classification is the temporal, the one that comes acute and the one that comes chronic. So if it's an acute first-time headache, you're thinking infection, trauma, maybe it's the first episode of migraine, but that comes after you've ruled out everything else. But if it's acute and recurrent, then you're most likely thinking of migraine as your main DD. Chronic is more than 6 months in duration. You think of a tension headache, a chronic daily headache, something that's there more than 15 days of the month for more than 3 months of a year. You're thinking of a chronic, non-progressive, a chronic headache. And chronic progressive is when it's a prolonged period and the headache changes either in variety, location, duration, frequency, any of that. It should ring a bell. That's the one you don't want to miss at any cost. So quick difference between the two, primary and secondary. Primaries are usually chronic. They go on for many years and usually more than 6 months. Secondaries usually come acute. Temporal, they're recurrent. This is progressive. Location can be temporal or frontal in nature. Usually secondary headaches are more occipital and maybe vertex. Quality is throbbing and squeezing, whereas secondary headaches are usually pressure. They'll tell you like the brain is bursting from inside. Time of the day for primary can be any time. For secondary is usually early morning awakening, maybe associated vomiting, nausea, more vomiting than nausea. The frequency can be intermittent, varied, hours, minutes, days, duration. Usually secondary headaches, they'll tell you it's constant and it just doesn't go away. Whatever I do, I can't get rid of it. And you may have auras in primary, you may have diplopia in secondary, and yes, the photophonophobia should be a clue to tell you I'm looking at primary headache. So how do I approach a child who comes to me in the clinic and says it's headache? As everything, the history gives you all the answers. You do realize something, migraine is a diagnosis by exclusion. So to do that, I have to rule out everything else, and really the history gives you the markers for everything. This is one condition I would tell you that speak to the child even before you may speak to the parent. You will be surprised how a 7 or an 8 or even a younger child can tell you exactly what he feels, where he feels it. He'll describe to you how it starts, where it moves, how it goes, how bad is it. You have to tell him when you're scaling it, scale it on a rate of 10, where 1 to 5 is livable. 1 is like it's just there somewhere at the back. 5 is unpleasant, but you can still do all your daily activities. And 10 on 10 is, you're just crying in pain, lying on the floor and pulling your hair because the pain is unbearable. And you'll be surprised how often children can grade themselves so well. Don't let the parent interfere. Invariably, mom will say, oh, tell her this or tell her that. You told me this, you told me that. Let the child complete everything, because very often the child then tends to say what the mom is trying to say. Go into deep detail, ask the child to even draw the aura. So you can see these are pictures of children who have drawn the auras. The flashing dots, and there's one little black line, and these are the colored semicircles which are there, which are in triangles and shapes and different shapes. Ask for the family history, mother, father, grandparents, benefits and losses. Is there some gain this child is gaining by any chance with this headache? He's like getting to miss the homework. He gets to watch more TV. Yes. A history which tells you he watches TV when he has a headache, straight away you know you're looking at something else. And look at the anxiety level of the child. Very often A-type personalities have more chances of tension-type headache. So when we're looking age of onset, when did it start in the beginning? What is the character of the headache? Is it pulsating, sharp, electric, ticklish? What is the duration? Seconds, hours, goes away the minute the homework is completed? Where is your headache located? What's the type of distribution? You can also, you can have headaches in the groin. You can headache in the calf. They'll just complain of calf pain very often. A migraine can come with just calf pain. Okay, the severity of it is vomiting, photophobia. Do you see webs? Do you see like I'm time travel? And very often if you ask them to draw, you'll see these lovely figures that they draw, and this is what they see. So from location of the headache, if it's around the TM joint, we know we are looking at the TM joint related inflammations. We have the sinus headaches, which is above the frontal, the maxillary, the ethmoid. Cluster headache, typically around one eye. Okay, so the whole area around the eye, tearing of the eyes, drooping of one eye, cluster headache. Tension headache is like someone has tied a band around your head and tied it tight, one of those elastic bands, and it's just squeezing you on the two temples and inside. Migraine is usually unilateral, will start with the temple and then move to involve the entire face. You'll feel uneasy. It may go backwards as well. In children, migraine is very often bilateral. So the unilateral features classical of adult, and usually children move from bilateral to unilateral by adolescence. And then you can have neck pain in the top and the back of the head, which is seen. You must ask for aggravating and relieving factors. These are the foods which are associated with it, but I do want to specify that in children, very rarely does food cause migraine. Food is more a significant feature of adult migraine, not so much children. But yes, you'll have the odd one with chocolates or ice creams, which can get precipitated. Cheese is something to be worried with children. Other triggers, we're all aware of smells, food, medication, sounds, lights, sleep, lack of sleep, weather, young children or adolescents who start drinking a lot of caffeine, which comes. Avi, can we just mute everybody else? Thank you.
Just looking into it, just a second, sorry.
Yeah, sorry. Caffeine, young adolescents who start drinking a lot of coffee when it's time for exams. Weather, many people will complain of it in particular weather. When? Sunny weather. So people who have bad migraine hate summer. They hate Octobers. Then there's hereditary aspects, stress, which can bring it on. So stress doesn't only give you tension headache, it can even precipitate a migraine headache. And if you tend to miss meals, etc. Family history, they say 90% of cases of migraine, one of the parents will have migraine history. So if you have a negative history of migraine in the family, you will think twice whether this is really a migraine. The younger age of onset and the longer the duration, usually both parents have migraine. So those who come with a more severe pediatric presentation have more bilateral. Risk risk increases if both parents have migraine, and then you have other neurological, psychiatric, or medical illnesses you need to look into. So how do you investigate? Who do you do imaging on? Who do you ask an EEG? Opthal examination, blood pressure. So basically, I'm going to run through who gets an MRI or an imaging. EEG, I would only do on those where I'm worried, am I looking at an epilepsy versus a migraine? Eye checkup is very small percentage of children with headache actually have eye problems, less than 5%, but there's no harm in sending for a routine eye checkup for acuity. Blood tests other than a sugar, so that I don't miss diabetes, pediatric onset diabetes, I don't routinely do any blood tests. And a BP, I take a BP in every child who comes for a headache. Even if it's not an occipital headache, I will always do a BP in every child. So these are the basic investigations. And for MRI, who would you do it if it's acute, if it's chronic progressive? It's changing, it's becoming more frequent, more intense, associated with new features, neurological symptoms. You think there's a suspicious structural abnormality. If it's persistently occipital in nature, younger child, the investigation of choice is the MRI. Here you see the MRI. It just shows this little bit over here, but when you do the DSA, and you can see this huge AV malformation, which was sitting over there. So we don't just do MRI. If you'll do MRI with an angiogram so that you don't miss vascular pathologies. Secondary headaches are the ones we are really worried about. This is the ones we don't want to miss. So whether it's infection, trauma, visual problems, low pressure, cerebral venous thrombosis, space occupying, benign intracranial hypertension, sinusitis, or psychogenic. We're just quickly going to run through a few of the secondary headaches. Post-traumatic headache usually comes within 7 days of the acute injury to the head or after the child gains consciousness. It can be short, it can be long duration. Okay, it's usually due to some degree of bleed or concussion or contusion which has happened during, and definitely an MRI is indicated. And you might need to use analgesics to prevent these headaches as time goes by. Cerebral venous thrombosis precipitated by infection, precipitated by dehydration, usually slow progressive, starts with a dull headache, becomes worse and worse and worse with every day. Slowly sensorium starts getting affected. You might get focal signs. Think of a cerebral venous thrombosis. Sinus headaches, we all know the frontal, the maxillary, the ethmoid. So the sign, forehead and frontal, they're triggered by infections and allergies, stress and odors. And very often you ask them to bend down and touch their toes and they'll tell you the head pains very badly. That's a feature of a sinus headache. Headache due to refractive error, usually around the eyes and usually above the eyes, which is over here in the evening when the child is tired after a long day at school, particularly now when he's doing online schooling. Idiopathic intracranial, what you used to call benign intracranial or pseudotumor cerebri in the past, very often starts like a migraine but doesn't go away. It becomes worse with time. It might eventually lead to visual problems. You do a Valsalva's maneuver or you change the posture and the pain becomes worse. You might with time get neck stiffness, which is transient, and then last you'll get visual issues. This is just a list of few of the conditions which is associated with benign intracranial hypertension. And the treatment of choice is first should start with medication such as acetazolamide to cut the pressure in the brain. You'll first do a lumbar puncture to check the pressure which is over there. Very often the child will need repeated lumbar punctures because the minute you do the lumbar puncture, the headache settles, the child improves. But you have to be careful if you're doing too many lumbar punctures, you don't want low pressure headache. How does a low pressure headache manifest? The minute the child sleeps, she's fine. The minute the child sits up and starts walking and moving, the headache starts. Okay, why is this? Because when you come with gravity, the brain gets pulled, the pressure is low. As a result, you get a Chiari malformation and you get low pressure headaches. Okay, so you might have visual concerns with idiopathic intracranial hypertension. And the last resort of treatment, if nothing tends to work, you might put a lumboperitoneal shunt. And lastly, you might have to do optic nerve fenestration if the pressure on the eyes is too much and we run the risk of losing vision. Headaches such as secondary to SOLs, most SOLs will start with headaches. They will be non-specific and indolent to start with, but they will change and become progressively worse as time goes by. What are the headaches? If you come and awakens a child from sleep, you're looking at dependent edema of intracranial lesions. If it's nocturnal or early morning, you're thinking of tumors which are sitting at the floor of the fourth ventricle. If it's behavior and mood changes, all SOLs will be related with behavior issues that happen. If it's loss of vision, you're thinking of something midline, craniopharyngioma, or optic pathway tumors. If you're getting diplopia, you're thinking of brainstem and medulla. If you're thinking ataxia, you're thinking cerebellum. If you have seizures, You're thinking this is coming somewhere from the cortex with cortical distribution, and there will be a focal sign to it. Chiari malformation, relatively rare, but will give you like a negative pressure headache, which is precipitated largely but worsens with flexion extension or if you do a Valsalva's maneuver. We now come to the most common type of headache in the pediatric age group. Okay, the secondary headaches are the ones you don't want to miss. They need imaging, they need looking into, they need lots of investigation. Migraine headache is the commonest, but is relatively more benign. 10% of children from 5 to 15 years will have migraine. That's not a small percentage. 2.5 under the age of 5 years, 7 years. Less than 7, always think organic. If a child less than 7 comes to you with a headache and tells you so on his own, do not ignore that child. Please investigate that child. 5% from age 7 to puberty. Here females are more than males. And 5% in post-pubertal boys and 10% in post-pubertal girls. And you can see the graph again here, and it's usually triggered by the onset of menstruation. So what do they feel? They feel a headache, they feel dizziness, they feel nausea, vomiting, they have frequent yawning at the start. They may say the neck is very tight and very stiff. They become very moody and cranky. They get constipation. There's blurred vision, which is there. Lack of sleep comes into the picture. They get very sensitive to weather changes. They hate loud sounds. They hate certain smells. They hate bright lights. And they feel very thirsty all the time. So the migraine classification are those with aura, those without aura. In the aura, we have certain features. We won't go into the details. You have something called chronic migraine when you have more than 15 episodes in a month and more than 3 months duration. You have status migrainous where you're in a headache continuously for more than 72 hours and nothing seems to relieve you. And you have migraines which will then trigger seizures. You'll start with a headache and then it goes into a seizure. You have episodic events, which is cyclical vomiting or what we call the migraine variants. So we're just going to run through this quickly. Migraine with aura. So you have certain criteria. You need to have more than 5. The aura has to be of without aura. The headache has to be pulsatile, unilateral, worsening, moderate to severe with nausea, photophobia, phonophobia. And there should be no other cause. The E is very important. There should be no other obvious cause for the headache. Okay, and then you have migraine with aura, which you need at least 2 attacks, but these are the symptoms: vision, sensory, speech, motor, brainstem, or retina. These are the different features, the duration. This is going by book, but basically you get these features in front of your eyes, or the smell, you can hear or see things bigger or smaller. And then you start getting this throbbing headache, which usually is unilateral, can in children go bilateral. You have something called hemiplegic migraine, which is particularly in small children, where you have a visual aura and you see visual hallucinations, and then you lose sensation and you use motor control over 1/2 of the body, and you get a sensory aura, which is over there. You might become drowsy a little bit at the end. So it's very scary because you think you're going in for a stroke, but the aura is the giveaway. So you have this aura with straight geometrical figures. Okay, migraine always gives you geometrical figures. We'll come to that later. And these are some genes which are associated. What are migraine variants? And these are important to know because very often these children are extensively investigated with thousands of investigations which are not really needed. So you have brainstem migraine, which can come with an aura which is associated with vertigo, tinnitus, hyperacusis, diplopia, ataxia. But again, it's transient. It lasts for a few minutes to some time, and there is no other explanation, and it goes. You have cyclical vomiting. Very often in young children, they just vomit, 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 and invariably they go to the gastroenterologist. They have every scan possibly done, multiple USGs, barium study, blood tests which are done for the vomiting, and at the end the penny drops that this could be cyclical vomiting because it happens at regular intervals. So it might happen once in 2 months, once in 4 months, and then you have these attacks which are multiple within a day. You vomit multiple times, and then there's no other cause which is identified. And there'll be a family history of migraine somewhere along the way. Abdominal migraine, again, you get this feeling of uneasiness, just a soreness in the abdominal region. The associated anorexia, nausea, vomiting, they become pale. They become any autonomic feature when it comes with a headache or other, you must think migraine first. So either pallor or excessive sweating or tearing or any of that, you'll think of a migraine variant. There's something called benign paroxysmal vertigo. And you'll have little children come in. So I have this 4-year-old boy who'll come and then he'll just start swaying over there because he can't stand straight and he tends to fall. And he'll tell you very clearly, the whole place is spinning around me. Okay, so he has nystagmus, ataxia, vomiting, pallor, fearfulness, and he just runs to hold on to his mother at that time. You could very easily understand how this is mixed up with epilepsy, but when you rule out everything else, you'll realize that this is a benign migraine variant. And the next is a torticollis. They hold their neck in this state. There's associated pallor, irritability, malaise, vomiting. Again, it's transient. Few hours, he'll hold his neck like this, and then it comes up over a period of time. So when you look at migraine, children have the same features as an adult. You have these features which are premonitory, that something might tell you that it's going to come, and they start yawning very frequently. Then you have the visual auras, and that, again, this is seen more obviously in older children who can express an aura to you, but you'll be surprised how even 8 and 9-year-old children can tell you an aura and draw it for you beautifully. Then comes the headache, which is with nausea, vomiting, and all the features. And then you have the post-headache phenomena, where you feel absolutely drained, tired, exhausted, and very often the person wants to just go to sleep over here. So one of the common problems we have is migraine and epilepsy. How do you differentiate? Is this a migraine episode or is it epilepsy? We know occipital epilepsy can give you things in front of your eyes. One very clear way to distinguish is that migraine usually always comes in geometrical figures. The lines are always are straight and at angles. So this is how a person reading a book, this is what would look if he had occipital epilepsy. He might have the same dots, but they're colored and they're rounded. They're complex forms. While a migraine person will always have it jagged, triangles, squares, shapes, rectangles, all geometrical figures, and you might go blank in that moment. You have a scotoma there. So this is what an epilepsy would look like, complex figures. So this is a child who has drawn what he sees when he's having this so-called occipital epilepsy and his simultaneous EEG showing the discharges. And a person with migraine will have those geometrical type of figures, usually black and white, but you can get color in them as well. So now we have a case to start with. This is a young boy of 11 years who's referred to by an ophthalmologist for headache for the last 6 months. He said it was cephalic, means the whole head, but he kept saying at the end it comes up to the front at the vertex. It was intermittent. It was started with once a week, then it went to 4 times a week, and it ranged from 2 on 10 to 8 on 10. He had no associated vomiting, nausea, photophobia, phonophobia. I must have asked 100 times whether any of that, and he said absolutely no. He couldn't tell me if there were any precipitating or relieving factors. It did not interfere with his academics, his school days, or his activities, but he said it was always there. But now, since October and November, the headaches have become much more frequent. They're now daily. They're all day long, and now they never seem to go away. And he's talking to me very calmly, very graphically describing everything. And he says, I'm sitting here, but my headache is 3 on 10. So they went to the ophthalmologist as referred by the pediatrician. The ophthalmologist was worried by what he saw on the fundus. He asked for a perimetry, and this is what he got on perimetry. He had a bitemporal hemianopia. So you can see you get a bitemporal hemianopia when you are sitting in something which is at your chiasma. So sure enough, he came to me and it was a very frequent, it was persistent and chronic, progressive in nature, not relieved by anything, no family history that I could depend upon, no aura, and no frank associated. Now we have a CNS symptom in the hemianopia, and he had this huge craniopharyngioma sitting inside him, subsequently operated recently. But just to see that you can be carrying something as large as that, and all you presented with was a headache. So now to the management, what are we looking at? We want the improvement of the quality of life. We want to avoid the headache and avoid medications as well, if possible. We want less frequent, less severe, less duration and disability, less headache-related distress and psychological symptoms, and we need to educate and counsel the patient so that they know how to deal with it. So what I always tell parents when they come is that 50% of the world has headache. So if we have 50 people in the audience today, 25 of us have migraine and 25 may not have migraine. Okay, that's huge. That means 50% of those of you who are listening to me actually have migraine. I, for one, do have it. You get it? So this is a lifetime condition. This is not something you want to run and treat immediately. This is something you only want to treat if absolutely necessary. So management is divided into pharmacological and non-pharmacological. And in pharmac, you say acute treatment. I have the headache now. What can I do? I'm having very frequent headaches. What can I do to prevent it? So just to cut a long story short, this is all the evidence base which is there. And you can see out here that ibuprofen and acetaminophen. Ibuprofen is distinctly much better for migraine headaches than paracetamol or acetaminophen. So if you can, please prefer ibuprofen for a headache, moderate pain relief by 2 hours. The next one is for the triptans. Sumatriptan and sumatriptan with naproxen has a much better outcome at 2 hours. We routinely can give triptans to children, not to worry about it. We'll discuss it. And the last is zolmitriptan, which is also possible in children today, has the best outcome and the fastest action. In 1 hour, you have moderate pain relief. In 2 hours, you have high pain relief. So from the pain relief, ibuprofen has the best. Naproxen hasn't been tested in a study, but ibuprofen has distinctly better. And sumatriptan and rizatriptan can be used in the pediatric age. So what are the triptans that we have? As per the FDA that we have now, greater than 12 years, 3 of them have been approved. Rizatriptan can be used 6 to 12 years or 6 to 17 years, but most of them which come with the bad headaches are 12 to 15 years of age. Okay, so these are the triptans and how they work on the vascular to cause vasoconstriction. And what's the situation of triptans in India? Rizatriptan, you can get oral tablet 5 and 10. You get mouth disintegrating. This picture out here. It's a little tube they give you, like little, you get those, as kids, you get those things you put on your tongue and it just dissolves and melts. So that's what you can get because you're in so much pain, you just actually put it on your tongue and the absorption is very fast. Sumatriptan, you have injections for status migrainosus, you have tablets, and you have a nasal spray, which was available until recently, and for some reason it's gone off just now, but hopefully it'll come back. So this is the nasal spray for sumatriptan. Zolmitriptan is mouth dispersing and nasal spray. Almotriptan is tablet, and Suma with naproxen is an oral tablet. And these are the dosages if anyone's interested. So in the emergency room, if you come with status migrainosus, then the drug uses prochlorperazine, metoclopramide, NSAIDs, ergotamines, anti-epileptic, IV sodium valproate can be given, and intravenous triptans can also be given in the case of emergency. Now, this is if your migraine attack lasts more than 72 hours, is unbearable and cannot be treated by anything else. Not going to go into ergots, not used so routinely in children, but in that rare occasion, it can be used. So now when we treat children, how do I guide the child? I actually tell the child. I tell them, see that you have your naproxen or your ibuprofen in your school bag or with you at all times. If the child has bad headaches, you might actually tell him to keep the triptan with him as well. When the headache starts, you don't wait for the headache to reach the peak. When the headache starts rising or the aura starts coming, you pop your ibuprofen immediately. If the headache doesn't settle with the ibuprofen in the next 10 to 15 or 20 minutes, you may consider starting or using a triptan at this time. This is called stepwise treatment. Stratified treatment is where you teach a person how to understand how bad his headache. If it's mild, he'll only take the NSAID. But if he knows from the beginning that this one is going to be a whopper, I'm going to be out for the better half of the day, you don't wait for the NSAID to fail and then start the triptan. You give both together, the NSAID and the triptan together, so that you hit it hard and you control it. And then if you go into status migrainosus, these are the other drugs that we can use. So who do you put migraine prophylaxis on? About 1/3 of adolescents meet the criteria for preventive therapy. Yet only 10% receive preventive therapy due to underdiagnosis. Who needs prevention? Those who get more than 3 to 4 migraine attacks per month for at least a period of 3 months. They are frequent, they are incapacitating headaches, and they have severe headaches which are interfering with activities of daily life. So, this is the single most important factor. Who will get prophylaxis if the child's everyday activities get affected, if he's not going to school regularly, if he can't finish his homework, if he doesn't go out to play with his friends, if he can't go for the school picnic or the school outing, or he has to sit in class because everyone's going to play in the playground and he hates being left alone in the class, it means it's interfering in his everyday life. That child needs prophylactic treatment because we want him to live a normal childhood as far as possible. So, what are the preventive therapies we have? We have antidepressants, anti-epileptics, antihistaminics, and antihypertensives. To cut a long story short, the anti-epileptics that you can use is sodium valproate, very effective. Topiramate, not so effective in the pediatric age group, but starts becoming effective as you become adolescents. So once hormones kick in, and once the child tends to become present like an adult migraine, topiramate works much better. They take as little as 25 milligram, 1 tablet a night, and that's usually enough. Levatricitam has been tried, zonisamide has been tried, amitriptyline has been tried. Cyproheptadine can be tried in these patients, quite effective, but it has its own set of issues. Propranolol, somehow I don't find it so effective in the pediatric age group, but very effective in the adult age group. The drug of choice for prophylaxis in migraine is flunarizine, calcium channel blocker. I have maybe in all these years only 2 or 3 children who have not responded to flunarizine for pediatric migraine. You can safely start it any age group until they reach about 15, in which case the flunarizine may not work so well. But a 5 milligram tablet, 1 tablet at night, HS, 2 side effects. It makes you slightly hungry, so weight gain is a big problem, and it makes you slightly sleepy, so only give it at night time. If 5 milligram doesn't work, you can go to a 10 milligram, but again, the side effects are a concern. And remember, flunarizine takes at least 10 to 15 days to kick in. So if you give the tablet today and mom thinks the headache's gone by tomorrow, she's mistaken. And you need to tell her that, otherwise she's going to run to the next doctor saying, see, he gave this medicine and nothing has happened. It takes at least 10 days for flunarizine to kick in before the headache starts settling. And then riboflavin, CoQ, magnesium, these are other supplements that you may try. How long would you continue treatment? Ideally 3 months. If it's a really bad migraine and it took time to control, I would say 6 months. Then you stop the medicine and you wait and see. Migraine comes in spurts. So you're going to have a few really bad months, then you may have months or years with nothing, and then it may come back again. So you will only treat at those times when it is really bad. Intermittently, if it comes and goes, no need for treatment. You counsel regarding relapses so that she knows that it can come back again and she's not shocked and surprised. And very often we identify the parent with migraine after the child comes in, and then we refer them, and moms are very often so relieved because she says, I've been living with this pitta all my life and I didn't realize that this was migraine. The most important part of migraine treatment is non-pharmacological treatment. Single most important is sleep. I wish we could do a talk on sleep one day and sleep disorders and the importance of sleep in children. But look at the hours you need. A 3 to 5 year needs 10 to 13. A 6 to 13 years needs 9 to 11 hours. No 13-year today sleeps 11 hours. 8 to 10 hours for a 14 to 18 year, they need 8 to 10 hours. And 25 to 45, which is a large chunk of y'all in the audience, which is 7 to 9 hours. And those of us who are 45 and up, we need 7 to 9 hours as well. So sleep is a very, 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 very important aspect of prevention of migraine. Fluids is the next most important. You need at least 3 to 4 liters of water a day. A rough costing, 10 kgs, 1 liter, 20 kgs, 2 liters, 30 kgs, 3 liters, and then 3 to 4 for the rest. Okay, so that's a nice way if you want to know how much fluid to recommend for the child. Diet, they can eat everything. Do not do diet restriction in pediatric age group. If and when they complain that it might be food related, we'll see. Exercise, very good, because the endorphins are very good neurotransmitters for the brain. If the headaches are very bad, cognitive behavior therapy. And yes, as they grow older and they can understand the value of yoga and meditation, you go into alternative options. But most important is avoid the triggers. So what do I tell children? I have a kid who's a tennis champion. Can you imagine? He goes out in the sun, and the minute he goes out, his headache starts. And he's a national tennis player. So you have to wear a topi. You have to have those tinted glasses, which become sunglasses the minute you go out. And you have to see that you try to play in those hours of the day where the sun is not at its worst. So 2 to 4 is a no-no, but the rest of the day is okay. So if it's fatigue, if it's straining, if it's concentrating on the computer, if it's the bus, very often children will say, I sit in the bus and the noise upsets me. So put earphones and just don't talk at that time and go through the bus journey with music in your ears, or walk home. Or maybe a parent has to come and pick you up if it's really bad. So whether it's smells, it's perfumes, etc., you need to just avoid what brings it on. And as far as food is, this is not so much for children. But I put this slide in because it's more for the yous and me's who have migraine within us. Some get it with gluten and wheat. Cheese, why? Because it's fermented. So wine is fermented, cheese is fermented, dried fruits are fermented. So these are the things that can give it to you. So some fruits, particularly the berries, cranberry, gooseberry, fortunately we don't get so many of them here, they can give it. Chinese food very often gives you severe migraine. Alcohol, chocolate, certain breads. Why bread? Yeast. The yeast of the bread, which is there. Okay, again, the nitrates. This is the process. For processed foods, they put this to ferment the stuff so that it's there. And coffee can do it. Some say the migraine goes with coffee and some get worse with coffee. And the last 2 slides are on the 2 different types of headaches, which also need to be mentioned. And these are tension type headache, which is relatively benign. It's in this position that you can see. It's like a band behind you, and it'll be at the back of the head. And very often it'll go back to the base of the neck because it comes up from the cervical because of the stress in the shoulders. Neck and shoulder pain. It gets worse as the day progresses. It may last for days. It's usually a chronic headache, and it's usually a stressful event which may bring it on. And sleep may relieve the headache temporarily, but then it comes back again. And then you have cluster type of headache, which is not seen commonly in children at all. But whereas migraine can get eye involvement because of the hemi involvement, cluster headache only has involvement of the eyes. Because the conjunctiva becomes very red, it starts tearing, this eye becomes heavy and droops because it feels so heavy because the pain is so excruciating. And while this is a tension headache like this going all the way back, this is a migraine headache, which is hemi and goes to the back. And this is a cluster headache, which tends to localize itself around the eye. So in conclusion, headache is a very common pediatric problem. The primary aim of taking a good history is to identify whether you are primary headache or secondary headache. And particularly in young children, you cannot afford to miss a secondary etiology at all. However, in spite of everything, you'll realize that majority of your patients are primary headache, of which the majority of 75% will be migraine. So this concept that migraine is a problem of older people and adults is a total no-no. It's very commonly seen in children. Learn to realize and identify it so that you can make that child's life a little easier from the beginning. It varies a little bit from adult migraine because the young ones may not tell you the aura. The young ones may have bilateral. The young ones can sometimes have an aura even without a headache. They can just have, I can see something smaller, I can see something bigger, I can hear people talking in my ears and no headache comes after it. So just keep it in mind that these are variations of migraine. Okay, and it evolves with time. When he's 7, it's different. When he's 10, it's different. When he's 15, it's different. And then it gets fixed into what you get as an adult. Medication we recommend only if it impairs daily activity. So you try to see whether the child can cope, give him the normal stuff, the non-pharmacological, but you feel if it's interfering, don't let him suffer the pain. please give him a 3-month course of the medication. But more important is alternative lifestyle changes, because this is a lifelong condition. So with this, we end with two very nice, this is a picture from the past of someone with the headache and how he thinks the devil or the demon in his head, because he just can't function when this happens. And this is a young girl's drawing of her headache. And she describes how she feels drained, sick to the stomach. Everything is always on the left side only. A pinchy nerve in my shoulder. I have a tight ache in my neck. It's stabbing in my eyes. It's throbbing in my head. I have tingling all over my scalp. If you have an allodynia, they just feel, you touch them and they wince because their hair and all become so sensitive. They have a droopy eyed, blurred vision, and a foggy mind. And with that, I end. Thank you, and happy to take any questions.
Thank you, Dr. Anaita. That was a beautiful lecture, and been getting a lot of plaudits on YouTube for your lovely slides. So Dr. Narvekar had raised his hand before. So if you'd just like to unmute, if you have a question, can ask right now. Yes, he's so till then. We've got another question till he joins in. Dr. Merchant has asked, does steroid have any role in the status migraines?
Yes, steroids can be used. Hydrocortisone sometimes is very effective. 100 milligrams hydrocort IV stat can be very, very, very effective. But again, it's largely in adults. Status migrainous, in all these years, I may have had about 2 or 3 children who come in with status migrainous. And if it is, it's going to be those 15 to 18-year-olds who literally now have fallen into the adult age group. So you would treat them like you would treat an adult with it. So yes, there is a role for status migrainous.
All right. So till we wait, if Dr. Narvekar comes back, just ask a few questions. Ma'am, like you've pretty much covered everything in your slides. Would you what in a single short message, if you'd like to give, is when really should either a family physician or a parent should be concerned when their child is having an headache?
So if you have very frequent headaches, if you have headaches which are becoming worse as time goes by, if you have a headache which wakes you up in the middle of the night, if you have headaches which are associated with vomiting, particularly in the morning hours, I would say these would be my red flags for sending the child immediately for investigation.
All right. Ma'am, we have
Madam, may I ask one question?
Yes,
Sure.
yes, please.
Can we use propanol in these kids? And if at all you want to use it, what is the dosage?
So you can use propranolol in these kids. It's 1 milligram per kg. I have not found it so beneficial in the young kid, but yes, I definitely find it beneficial in that 15 to 18 juvenile, adolescent, young adult category. In the young child, I cannot tell you how effective flunarizine is. You just have to start one. I'm telling you, in all these years, there may be just a handful. I can actually count them on my fingers, those that need 2 medications instead of just one.
All right. And there's another question. Can you tell a little bit about treatment of cluster headaches?
So cluster headache, again, is more pain relief. They come intermittently. They are relatively benign. They come around the eye, but they give you like, you feel like you've got a, it's excruciatingly painful, like a stabbing in the eye, which is there. It's sometimes short and brief, not very long, and it's pain relief only.
Another question has been asked is, can you tell us a little bit about acidity-related headache?
So that's what I'm saying. Most people think that this acidity that you have is really the nausea that you feel because of the aura of a migraine. So most mothers tell me, apne ko pitta hota hai aur pet mein darad. They won't tell me, they won't talk about the headache so much. Because I always ask, aapko headache hai? And she'll say, nahi, mujhe to kuch nahi hai. I say, aapko pet mein kuch hota hai? Haan, sir darad ka bhi aise pitt hota hai andar. So basically, they are looking at the acidity, and really that is all migraine.
Excellent. There's another question from Dr. Kulkarni. How long do you give flunarizine prophylactically?
So I usually recommend it for a period of 3 months, because by the time you break the cycle and you keep him in that state, it's about 3 months. And then if the child responded to flunarizine immediately with no problems, I stop it at 3 months. If the mom says it took very long, the dose had to become higher, it took a little time, and he still has intermittent once in a while headaches, I would go for a 6-month period. But that is patient to patient. But I would definitely at 6 months take it off, because invariably they go into remission at that stage, and you wait for the next episode and then you treat again if necessary.
There's
Madam,
another
in long
question.
term,
What if?
Madam, in long-term
Yeah,
use of
please.
flunarizine, does it cause some extra pyramidal side effect?
No, sir. Flunarizine doesn't cause. Metoclopramide, chlorperazine, they cause extrapyramidal. Flunarizine does not cause extrapyramidal side effects. But the concept is that in migraine, we shouldn't be taking any long-term medication. We need to address the acute. I'm talking pediatric. If you're asking me adult, it's totally different. Because adult migraine, invariably, they take medicines very long term, years at a time. They'll stay on a small dose of Topamac, Valproate, propranolol, maybe combination medication. But for peds, try and take it off in 3 to 6 months. But yes, if the minute you take it off, he relapses again, he needs it long term.
Ma'am, there's a add-on question to that. What if flunarizine doesn't work? If the child does not respond, what's your next step?
So if flunarizine doesn't work, first I see whether flunarizine has made no difference. If flunarizine has made some difference and it's 50% or 80% better, I do an add-on. Which is the add-on of choice? To me, sodium valproate works a little better in children than topiramate. If she's older, I would do Topamac. If it's a young girl, I'm not going to do valproate. I'm going to do Topamac. Why? Because valproate causes weight gain. Flunarizine also causes weight gain. The last thing I want her to is put on weight and feel terrible about herself. Topamac causes weight loss. It's the ideal drug for a young girl. If it's a boy, I'm happy with either of them. I may do valproate or flunarizine. If not, then I would do propranolol. If not, I would do amitriptyline.
Just adding on to the same topic that we're going on. So Dr. Preeti Bhargava has asked, like, does flunarizine require to be tapered, or can you just abruptly stop it?
Ideally, you could abruptly stop it. I taper it. I make it from 1 tablet to half a tablet for about 2 weeks, because just in case it's going to relapse, I don't want to make him come back into a full-blown headache and then start again. If she complains that in those 15 days the headaches come back, then I put it back on. If not, we take it off.
Then we have Dr. Vinita Shetty asking, chronic sinusitis related headache, how do you treat them?
I think you need an ENT, but ideally you need to decongest the sinuses. So you take a mucolite, or you take one of those. They'll usually give you a nasal spray. But remember, even the treatment of chronic sinusitis is not just till the pain goes. You need to take the spray and the mucolytic agent for a prolonged period of times for decongestion of the sinuses, and obviously prevent or avoid the precipitant. So invariably it's allergens or it's infections, avoid that chronically. But I think ENT would answer that better.
Dr. Narvekar has asked, it's a clinical question, how can you differentiate between the aura of migraine and epilepsy? Any tips from your side?
So that's really what I described. The migraine, occipital epilepsy. Only occipital epilepsy gives you an aura. It will give you complex figures. So in an epilepsy, you will see colors.
Can you please mute yourself?
Okay, so in the occipital epilepsy, you'll see complex figures. So you'll see a man walking, or a person moving, or a picture in front of your eyes. And in migraine, you will see either a lack of a picture, and you will see usually black and white colors, and you will usually see geometrical designs. So the difference, the main difference is color versus black and white, complex figures versus geometrical straight line designs.
Ma'am, the other thing now, as a specialist, what is your cutoff that you would say, no, now this is high time you refer it to a specialist? And regarding the investigations, do you advise that all the investigations you spoke about should be done previously, or it's better done after a specialist has seen them?
No, so taking a BP, I think everyone who has a headache, maybe we take one BP to see that we're not missing hypertension. I once missed a child of diabetes who presented with headache. So as a rule, I make every child who comes with headache to do a fasting blood sugar, at least so that I don't miss another one again. Um, Other than that, the EEG is very specific. It's only if there is concerns whether this is migraine or this is epilepsy, otherwise no role for an EEG. And unless you have any of the markers for who needs an MRI, there's also ideally no role for an MRI. But invariably an MRI is done because parents are so anxious. So I actually put it to the parent. I say, listen, there's no role for an MRI. I don't need it. But if you are super anxious and it will make you feel better and more comfortable, would you like to do an MRI? And she says, yes, immediately. They are paranoid that there is a tumor sitting in that child's head and they don't want to miss that. So sometimes we end up doing the MRI because it makes the parent less anxious. Then if the mother's anxiety goes down, the child's headache, trust me, solves much faster.
One more question, ma'am. Like you've spoken about alternative therapies other than medications. So for like headaches and migraines, are there any particular tips you would like to give the family or a parent? Like what can they do for the time being at home till they see their physician or get referred?
So the best thing to do with a migraine is, or even other headaches, is sleep. Okay, so go into a room, shut the lights, draw the curtains, put everything off, take away all the precipitants or the triggers, go to sleep. Very often you wake up, your headache is better. Very often you wake up, the headache is still there and as bad. See that you're well hydrated. I, for one, take a naproxen the minute, the second I feel it coming, I can start seeing dots in front of my eyes. I don't wait. That's the mistake I made for years. I don't wait. I take the tablet immediately. Many adult preparations have painkiller with domperidone so that the nausea aspect doesn't come in as well. So it's a combination medication. If it still doesn't settle, you take a higher level medication. But if you hydrate regularly, sleep well on an average, try to do some minimum exercise, and learn to calm your breathing and calm your mind, the headache can slowly go away. But trust me, sometimes it's easier said than done.
Thank you, ma'am. There's another question from Dr. Vinita Shetty. Can insomnia cause headaches in children? And if at all, then how do you treat them?
So yes, insomnia can cause headaches in anybody. If you and I don't sleep for a few days properly, we are cranky, irritable, frustrated with headache. So it's the same for children. So you need to find out, why is the child insomniac? Is it just bad habit and poor sleep hygiene? Or has he got some OMA, which is obstructive sleep apnea, which is there, and he needs to be investigated for adenoid tonsils, any of those things, which is blocking his sleep? Is he having night terrors, nightmares, any of that, which is interrupting his sleep? Does he have an underlying epilepsy, which is interrupting his sleep, which is there? You need to investigate why he has the insomnia. The headache is most likely secondary to the insomnia. So your primary problem is the insomnia.
Madam, what is incidence of trigeminal neuralgia in kids?
Very rare, sir. Very, very, very rare, unless it's traumatic.
Thank you, madam.
Right. Thank you, ma'am. Are there any more questions from the participants? If not, then we can close the first part of the session. Okay, there's one question that has come in by Dr. Kulkarni. In what situation should we revise the diagnosis of migraine?
If the frequency of the headaches, if the intensity of the headaches, if symptomatology associated with the headache, any of this becomes worse and becomes progressive, I would definitely go in and investigate. Okay, it's better sometimes to err on the side of being cautious. You don't want an AVM rupturing or something being missed. If something inside you makes you feel uneasy that this is not fitting in the migraine profile properly, don't take a chance. Just image him once and be safe at the end.
All right, we'll take one final question, ma'am. The question has been asked is there any ideal blood test for migraine?
No, no blood test for migraine, no test for migraine, period. Migraine is a diagnosis by exclusion. When you rule out everything else and you have nothing positive in your hand, that is migraine.
All right. Thank you, ma'am, so much. That was a lovely session. Thank you for answering everyone's questions. Before we move on to the next speaker, is there any line or some short message you would just like to leave our family physicians with so that they can also treat all types of headaches and pick it up as good as you?
I would just say, please listen to the child. Do not poo-poo a headache in a child and say, "Arey, just sir darad ho raha hai, leave it." It can interfere with their social, psychological, and emotional well-being. And though it may not be serious, like a migraine, every child has the right to have as comfortable and happy a childhood without chronic pain at the back of the mind. So please don't ignore a headache, investigate it, and then decide accordingly whether to refer or treat or wait.
All right. Thank you, Dr. Anaita, for that wonderful session. And now I'd like to invite our next speaker, if Dr. Rakesh, if you can just share your slide in the meantime. So the next topic is also a real interesting topic. And after talking about headaches, this topic gives a lot of headaches, not only to the physicians, the treating surgeons, as well as the patients as well. So the topic is push the poop. And we have Dr. Rakesh Shah, who's a very senior pediatric surgeon and has a vast experience in this field. His expertise is in neonatal surgery, minimal access surgery, thoracic surgery, and urology in pediatric patients. And today, as I said, he's going to talk on a very interesting and topic, that is push the poop. I'll welcome again Dr. Rakesh Shah, if he can start sharing his slides, and can sir, if you can start your video.
And the video. Two things. Is that okay? Am I audible enough?
Yes, now you're audible and see.
We're online? Okay. That was a lucid talk by Anaita on headache. But what I'm going to talk, that problem causes headache to all us doctors. I think, headache because of constipation. Now we know this movie which has come earlier. Rasik can answer the question. Who's this movie made by? Okay, forget Rasik is not around, I think. It is made by Sujit Sarkar. It was released in 2015. And the theme of the movie, a hardcore Bollywood movie, the theme was constipation. And there were big Bollywood actors acting in it. Okay. And what was the tagline? Motion se hi emotion. That was the tagline. So the whole movie was based on constipation. So from headache, we come from top to bottom. And this was a Bollywood blockbuster. Next slide, 1 second here. Sorry. Okay. So, yeah. It's not as simple as it is shown in the picture. And I've called it poo-oo, not P-O-O-P. Poo-oo stands for, it is a noun also, and it's a pronoun also, and an adverb also. So this is one of the most difficult things that is required for children. It takes up a lot of time in our clinic. The first time the child comes for consultation with the parents, you're looking at least 45 minutes. And for a surgeon, that 45 minutes, start my video. Okay. Okay, sorry. For a surgeon, this 45 minutes is a bit too much. We don't have that much patience like the physicians have, like Anaita has. And we deal with various age groups, right from infancy to adolescence. So the infant have different reasons for the constipation to happen. The toddlers have a different reason. The preschool kids have a different reason. The adolescents have a different reason. So it is going to be very difficult to connect all the dots in this talk, but we'll try to understand the evaluation and the management of constipation in children and try to work it out based on that. Now, what is constipation? Anybody? Achha, this is not a two-way thing. So, Avi, can you answer if you're okay? No?
Yeah.
What is constipation according to you?
Infrequent bowel movements.
Very good. Hard feces, then painful evacuation of feces, nice big feces that you pass with a lot of difficulty. And in older children, we have fecal incontinence. We call it encopresis. These are the indications. And sometimes you see children which are holding back, child which the stools are coming down, but he's holding back. Okay. Now this was developed. It's amazing what people think of, how your stool is looking. I'm surprised with that lecturer from Bristol Medical School, University. He has typed the type of stools into 7 types based on what he sees. And the type 1 and type 2, as we see, are what the constipation is all about. Whereas 6 and 7 is diarrhea. So first, to find out constipation, we need to know the normal stooling pattern. Now in the newborn, the first time the child would pass stools is most 95% of them would pass in the first 48 hours. That's what we call meconium. In breastfed infants, it would be very available, predominantly breastfed infants. If a child passes stools once in 8 days without any difficulty, that is also normal. If he passes 13 to 14 times or 15 times a day, that is also fine. But usually they would pass about 3 times a day. In formula-fed babies, the frequency goes down. And it's also based on whether milk-based formula or a soya-based formula. The toddlers, the frequency goes further down. And with advancing age, the frequency goes down because the GI transit time decreases as you grow older. In us, as elder adults, we have about 2.5 to 3 days is a transit time from oral to anal. How often do we have constipation? The prevalence is very high. Almost 30% of the children in childhood would have constipation. And it would account for about 3 to 5% of the visits to the physician, the caregivers. Maybe the family physicians or maybe the pediatricians, either of them. The preschool time is the most common time when they have this functional constipation. And the functional cause, habitual constipation, what we call, is 95% of the times. But we should not miss the other 5%, which is because of the organic cause. That's why we do the further investigations and evaluations that we are going ahead with. Now, this is Rome Foundation is a non-profit organization based in North Carolina. It used to do scientific data on educational information on previously what was called functional gastrointestinal disorders. But now it is called disorders of gastrointestinal interaction. Now, they give out criteria at every stage. Now, the Rome 4 criteria had come out in 2016. And based on the Rome 4 criteria, it's looking very complex, but it's not very difficult. I'll tell you. They have divided the childhood constipation in less than 4 and more than 4. And the criteria is basically less than 3 stools per week, excessive retention of stools, painful bowel movements, as what all the things that Avi had mentioned, presence of large fecal masses, fecal incontinence per week, at least 1 in older children, and history of retentive posturing or excessive holding back of stools, which is called retention. We'll come to all these things later. It looks a bit complex, but when it is present for more than a month, that's when we call it constipation problem. What are the causes of constipation? As I told you, 95% of them are functional. The preschool children, as we know, are the more commonly involved. it requires, as we told, 2 out of the 6 criteria said in that Rome 4 classification. The organic causes need to be excluded, and less than 5% have organic causes. The children who have organic causes usually start very early in life with constipation, usually in early infancy. We'll come to all the late things later. Now, there are psychologic causes of constipation is, as we said, functional. Sometimes it's related to the diet, food, protein allergy, cow milk allergy, then the fiber intake. What is this about fiber and constipation? What is the real food which has got fiber? Avi, do you have any idea what food has fiber? Avi, you want to tell me?
No, sir. This even I would like to know which real food has a lot of fiber.
Yeah. Anything that is green in color. Vegetarian food, green in color, that's all fiber, complete. Okay. Then fruits. Most of the fruits are brilliant in fiber. Then we have dry fruits. Dry fruits, prunes, raisins, figs, and khajur. These are the things which are very rich in fiber. Apart from, of course, the excessive, we can take isabgol, we can have high fiber intake, especially fiber created. So this is fiber. Okay, Avi? And there is something called a slow transit constipation, where the oroanal route time increases. That's why he's got constipation. Sometimes you get constipation because of inadequate fluid intake. You have to, the children need at least 1 to 2 liters of fluid per day. Am I audible? Hello?
Yes, you're audible.
Okay, sorry. I just got some small window in my screen saying that I'm logged out. So I was wondering. Then sometimes, because of any reason, you are unwell, you're immobile, you're injured, you're immobile, that can cause constipation. Then starvation can cause constipation. And neurological disorders also can cause constipation. One second, the slide is a problem again. Okay. Yeah. The neurogenic causes, the commonest cause which a surgeon's paradise is a Hirschsprung's disease. We are not going to discuss too much on Hirschsprung's, unfortunately, today. Then the mentally challenged children is a common cause for constipation. All spinal issues, myelomeningocele injuries, dystrophisms, these are all children who cause constipation. And of course, there are other rarer neurological causes. The endocrine causes, hypothyroidism, hypokalemia, cystic fibrosis, diabetes, and the other causes, rarer causes. The anatomical causes causing constipation is imperforate anus, most common for a surgeon, and an anteriorly placed anus. Normally, anus and the vestibule in a girl and the scrotum in a boy requires some gap in between. If the anus goes towards the scrotum or towards the vestibule, then it is an anteposed anus. These are the children who will have constipation. Quite a few medications could cause constipation, like opiates, anticholinergics, especially the tricyclic anticholinergics, antidepressants, chemotherapy, aluminum-containing antacids also can cause constipation. Now, what is the evaluation? How would one evaluate? And the goals of evaluation. The first and foremost, you have to separate functional from organic. Most important. As we know, 95% are functional, 5% are organic. But we do not want to miss a single organic cause. How would you do that? The commonest and the most important thing is a good history and a good physical examination. This, most of the time, almost 100% of the times, would take care of the issues. Further testing and investigations are required if you have a doubt whether it is a functional or it is an organic. Sometimes an evaluation in a good history can also identify dietary issues, can identify behavioral problems that are causing constipation. So these are important. History and physical examination is the mainstay. Now let's come to history. If we start with birth, the delayed passage of meconium, that goes, if there is a history of delayed passage, more than 24 hours, or especially more than 48 hours, it goes more in favor of Hirschsprung's disease. Now, when did the onset happen? Is it in the early infancy or did it start later on? Early infancy, one should think of an organic cause. Later on, more likely to be habitual. Did it happen during starting of solid food? Did it happen during toilet training? Did it happen when he went to school? Did it happen when he changed his school? All these questions are important. Then about the stooling habit, what is the frequency? Is it painful? How painful is it? The consistency and size. And is there bleeding associated? These are the questions one need to ask about stooling. Then are there accidents in the underwear? Normally in functional constipation, you would see a lot of accidents. In organic, accidents are almost negligible. Is there a foul smelling gas? Most of the parents say, डॉक्टर साहब ये बच्चा है ना वो बड़े जैसा पादता है बहुत बदबू आती है और बहुत आवाज आता है that means that this is a functional. Of course, dietary issues we come to. Same again. Bottle feeds is the biggest enemy for constipation. In fact, I tell most of my parents, if you're continuing the bottle feeds, don't come to me. You find a better doctor for yourself who can handle this. I'm not good enough. That's exactly what I tell them. Adequate fluids. Then fiber intake, we already discussed fiber. Then unusual diet with a lot of ready-made foods that is available. Okay, these are the things. Then we have to ask for underlying medical issues like congenital anomalies, abdominal growth. Is there a developmental delay, mental, physical? Is there abdominal distension? And we also need to know what treatment has been taken and what response has the treatment given to kind of assess what the cause is. We need to find out the family history of functional constipation, family history of Hirschsprung's disease, something like a celiac disease, or irritable bowel syndrome. Now on examination, what do we see on examination? We see one, abdominal distension, present or absent. If it is present, then less likely to be functional. When then there's a abdominal mass, mass means feculent mass or there is a SOL in the abdomen. That is also important. Feculent mass, more in favor of habitual constipation. If there is an SOL, more pelvic lesion, pelvic tumor, more in favor of organic. One also needs to examine the back and the spine for any cutaneous changes, tuft of hair, any swelling, any patch. Then when you start removing the pants, you have to see the soiled underwear. Whether underwear is soiled, that goes more in favor of habitual. And without doing a PR, one would look at the anus. If there's a wink, wink is how you wink at a girl. Avi, do you do that now after marriage? No.
No longer.
That's how we wink at a girl. What we do is we ask the child to contract the anus. The older children can help you do this, not the younger ones. And you see whether the anal tone is there or not. That is called anal winking reflex. Then the cremasteric lymphasis. Whether the scrotum halves are going up and down once you touch on that side of the thigh. There's a cremasteric reflex. If these reflexes are intact, anal wink is present, then neurologically child is intact. Lower limb weakness, of course, that is also important. Then you look at the anus itself, whether there is any fissure, there's any scarring, the position of the anus, whether it's abnormal, whether it's in front, or whether the size of the anus is okay or it's slightly smaller. We come to the digital examination. If you're doing a digital examination, what would one look for? One look for a sphincter tone, then the rectal wall, whether there's feces in the rectum, whether it is hard or is it soft. Then once you remove the finger, is it forceful expulsion of gases and stools that goes in favor of Hirschsprung's disease? And on the finger stall, one needs to see whether there's blood staining. That goes in favor of other causes of constipation. So now we come to the digital anal recti examination. If you ask me, I rarely do a PR examination for constipation. Most of my diagnosis is based on clinical questions and clinical examination. I rarely would do a PR examination because it is extremely unpleasant for a child, number one. And number two, it's not going to give any specificity or sensitivity for our diagnosis. And some of us, not me, but some of us would do a PR examination routinely, but they're not wrong. But it may be helpful to detect if any fecal impaction is there. But from the story of the mother and the family and the child, most of the time we know there is fecal impaction or not fecal impaction. But if you have a doubt, then putting your finger in is better. Okay. So then you also need to assess the psychological and environmental factors associated with the constipation. When did it start? Was it related when you started toilet training? Was it related when you started top feeding? Was it related when you started semi-solid food? Was it related when you changed school? Was it related when the diet was changed? All the psychological stresses, we all need to know that from the history. Now, this is a pain cycle. Once the child has uncomfortable defecation, he's going to hold on. Okay. And then that is going to increase the absorption and water and electrolytes from the rectum. So it's going to harden the stools even further, and it's going to increase the difficulty, and the discomfort is going to increase. So this is like a pain retention pain cycle. We come to the next slide. You'll show how it works. See, this is the PRP cycle, which is a specific cycle we see in functional constipation. On the left side, you see all the stressors, which we already described earlier. And this is the cycle: pain, stool retention, increased constipation, and then again pain and more retention, more constipation. It's like a chain reaction, vicious circle, as I call it. We need to break that circle at some stage for the management of functional constipation. And how we are going to do that, we will try and discuss it. This is the same thing. Quite often we see children, when Dr. Saab, the mother says that, Dr. Saab, ye to potty to karta hai, din mein 2-3 baar karta hai. But then we don't know what is 2-3 times. They pass little stools because they're holding on to the hard stools. We come to the slide in the front, and I'll explain to you the details about it. See, this is exactly what happens in a colon of a constipated child. Loaded rectum, loaded sigmoid colon, and a lot of fecal loading in the other parts of the colon. This is what happens in the rectum. The rectum enlarges, it thins out, the wall thins out, the nerve receptors are stretched, and the muscles don't work, the nerve receptors don't work. And there's hard feces stored in the rectum, and from the side, there's little feces coming out. So when the mother says that, Dr. Saab, ye to 3 baar karta hai toilet din mein, अच्छे से करता है. बोला नहीं वो that is not अच्छे से toilet. It is basically traffic jam हो गया है. That is how I describe to them. वो ट्रक और गाड़ी रुक गई है और साइड से साइकिल और स्कूटर निकलता है. ट्रक और गाड़ी तो अंदर ही है. That is how I describe to them. That kind of they understand pretty well. Now, constipation sometimes is also associated with bladder dysfunction. Bladder can be overreactive, it can be underreactive. Sometimes I've seen older children, we have seen quite often, with retention of urine. And once you give a single enema, and everything is fine. They also come with urinary infection because of constipation. So once you relieve the constipation, all this urinary dysfunction, bladder dysfunction gets better. Now, clinically, how would one differentiate? This is the only slide of Hirschsprung's that I have in the entire presentation. This is the clinically how will you differentiate? Hirschsprung's disease versus functional constipation. Delayed passage of meconium present in Hirschsprung's. Starts from early infancy, Hirschsprung's. Does not pass flatus as well as stools. In functional constipation, flatus would be passed, stool will not be passed. Perineal soiling will never be there in Hirschsprung's. The blast sign, after you do a PR examination and take your finger out, there's an explosive passage of flatus and feces. That is the blast sign, which is positive in Hirschsprung's, not there in functional form. There'll be failure to thrive in Hirschsprung's. And there'll be abdominal distension with visible peristalsis. And of course, investigations will help us to identify. Now, some children have blood in stools with the constipation. It must be identified that from where is the blood coming. Quite often they have fissures along with the constipation. So one needs to identify whether the fissure is bleeding or bleeding is happening because of milk protein allergy or other protein allergy, food protein allergy, or because of enterocolitis related to Hirschsprung's disease. Usually, clinically, when you ask the question, you would come to know. Usually, fissure bleeding comes along with the stools, or sometimes a few droplets at the end of the stools. And the rest of the bleeding, milk protein and Hirschsprung's, is mixed with the stools. It's like mixed properly. In the enterocolitis, there'll be a lot of mucus. And a stool examination may be helpful at this stage. What are the other tests? There are a long list of tests. We'll go through that later. But most of them would not require testing. And especially when you know that the constipation has started at the toilet training age, painful bowel movement, psychosomatic stressors, then stool withholding behavior, and there's good response to conventional laxatives. So you don't really need to investigate. Very rarely would a child need serious investigation. Sometimes, yes, I do investigate. This is a list of investigations that we can see. I do investigate, sometimes to relieve the apprehension that the parents have, to show them that, boss, everything is fine. You don't need to worry. Sometimes they come with so much anxiety and apprehension. Just to relieve the apprehension, sometimes we need to investigate. And rectal biopsy is also done rarely to rule out Hirschsprung's disease. We'll come to that later. Now, this is how exactly a plain X-ray abdomen of a habitual constipation would look like. As you can see, completely loaded rectum in the pelvis, right? This is why it happens. So we know we don't need to do a PR. Sometimes just taking an X-ray sometimes can help you. Even without the X-ray, we would know. But if you want, you can take an X-ray. Now, we also need to divide the constipation for clinical treatment basis into a recent onset or a long-standing. Usually less than 2 months, one would call a recent onset. It's easier to treat. And plain simple laxatives would work. Unlike the long-standing one, which will require intensive therapy and a lot of behavioral changes and a lot of education. Okay. And quite often, the recent onset constipation can also become a chronic long-standing issue. These are some investigations which are specially done. Anorectal manometry, not done all the time, but we do it sometimes to rule out Hirschsprung's disease and to see whether there is any anorectal dyssynergia. I'm not going into the detail of the investigation. If there are any questions subsequently, you can please ask me. Then another rare investigation, I've never done this in my life, but the list, just to complete the list, is motility testing, where they test the oro-anal transit time and the colonic transit time. And radio-opaque markers are given orally and at regular intervals, and plain X-rays are taken for 3 to 4 days to see how much time from the oral cavity to the anus and colon transit time. This is basically required for slow transit constipators, to when identify the slow transit constipators. Then there are some moments of truth. This is my nomenclature. It's not a nomenclature anywhere else. These are the moments where, mistakes can happen in life. Especially when you start top feeds to the child, when you start solid feed to the child, when you start toilet training, when the child starts school, change of school, change of atmosphere, change of diet. These are the moments of truth. That is when the parents and the caregivers have to be the most careful if you want to prevent constipation. The principles of treatment, as I told you earlier, prevention and anticipating and managing the moment of truths. That is the way. Identifying and promptly prevent a pain retention pain cycle, PRP cycle. The acute phase treatment requires disinfection. Whatever is lodged, all the traffic jam has to be eased off. There's a different technique for easing of the traffic jam and a different technique for the cops to kind of manage the traffic. We'll come to all that subsequently. And it is also helped with behavioral therapy, counseling, and patient education and family education. And follow-up phase ensures that constipation is resolved and regular stooling pattern takes. Now, usually in infants, it's easier to manage because it's a recent history most of the time, and it is tweaked. It has happened only because of change in diet. So most of the time, the dietary changes would take care of the constipation in infants. If required, we can give some mild laxatives in the form of lactulose, not even stronger than that. Very rarely, we may need a glycerin suppository, and extremely rare to use a phosphate enema. Next slide, thank you. Okay, now there is one condition which is called infantile dyschezia. What happens is there's a few minutes of straining and crying. The child cries, and then he passes a normal looking stool in an otherwise healthy child. This is called dyschezia. It's a constipation like symptom. It is not constipation. This happens because the child does not understand the process of defecation. It does not need any treatment or investigation. Only counseling is good, and it gets better with time when the child learns how to poop. Now, this is as we earlier also mentioned, that the recent onset constipation is much easier to deal with. Sometimes, and the most important thing sometimes you need to see is kick the bottle. Kick the bottle in the literal sense. It's very important part of the treatment in toddlers especially. I always tell them, as I told you earlier, that bottle feeds are on. Please don't come to me. You go to a better doctor. I won't be good enough to treat if a child is, if you continue feeding bottles to the child. That's point number one. Point number two is we have a habit of applying a lot of local applications for the perianal pain that the child gets. These, according to me, I think the local application is a complete no-no. They don't need anything. The local application is lignocaine, then you give antibiotic cream, then you give steroid cream. All these are in combinations. It's a complete no-no. Just a SIDS bath or a warm hip bath and oral analgesics would do the trick. And if you do good disinfection, everything will work out well. Now we need to discuss something on the toilet training. There's nothing like a good time for toilet training because it all depends upon the developmental readiness of the child. So one has to appreciate that when is the child likely to be developmentally ready. Because for toilet training, what it involves is communicating the need, then going to the loo, undressing, eliminating, wiping, dressing, flushing, and hand wash. These are the steps in toilet training. The child has to be mentally and developmentally ready to learn all this. But most often, around 2.5 years of age would be a reasonably okay time for toilet training. But it's not a rule. Toilet training can sometimes be associated with a lot of problems and setbacks. And that can be a moment of truth for all of us. Now, treatment of constipation, as we have almost discussed most of it, but tabulating it, laxatives, behavioral changes, and dietary changes. Three most important. The type of laxative, intensity of treatment is tailored based on needs. And the goal of therapy is the child should pass soft stool, ideally one per day, but at least once in 2 days, at least. Now, this slide depicts the understanding of pain, retention pain syndrome. What on the left side, you see that the loaded rectum, stretched out rectum, anal sphincter is spasm because the child is holding, and solid stool is held back, the liquid sometimes passes. That's what causes such soiling. So in the left picture, what you see is the thinned out rectum, the nerves and neurons and the receptors are all stretched out. So they don't respond to the stretched receptors that are there in the rectal wall and the pelvic muscles. Whereas if you consistent emptying of the colon, which may take months or years with laxatives and toilet training, you see the right side, which is a good picture to see, where the rectal wall, the muscle thickens and the nerves and the nerve receptors respond properly. That is what we want to achieve. This is called bowel retraining. After evacuating the bowel is retraining. This is the process. And we are going to see how you can retrain the bowel. See, we already discussed that the chronic constipation makes colon unresponsive. So how to retrain the bowel? One is the first step is disimpaction. Whatever traffic jam hai, usko nikalne ka. You have to clear out. Then you be a policeman. You need a prolonged laxative treatment to streamline the traffic once the traffic jam goes. And gradual tapering. If the policing goes, you cut down the policing and people will take care of themselves. This may take weeks, months, and unfortunately sometimes years. Most important thing is an education of the parents and the chronic behavior pattern of the disease. Negative attributes have to go. There are no negative attributes to the child. If you don't go to the party, aisa ho jayega. No, that's not right. Positive reinforcement. And it's not that you have to go to the party, only then you will get a toy. No, you go and sit there, you make an attempt. If you pass, fine. If you don't pass, it's fine. But you make an attempt. That is a positive reinforcement. Then involvement of the school teacher sometimes is essential to allow the child to go to use the washroom. It's very important for the family to know that framework of time involved. It's huge time. Sometimes I'll tell you months and years. And also important for them to know the relapse rate. It's almost 1 in 4 would relapse. So they need to know all this so that they come back to you, hopefully. So disimpaction, as I call you, is clean out. It's not like Virat Kohli's clean out, like what he's doing in Australia nowadays. Today also, I think, I don't know what happened in the... Avi, do you know what happened in the one day?
We weren't doing good.
After that, what happened? I don't know what happened, but 300 something we made, but it's clean out. It's a wipeout in the one-day series, I think. So disimpaction is always required when constipation is associated with fecal incontinence. Then there's a significant abdominal mass of feculoma present, history of incomplete frequent voiding, and any other investigation like a PR examination or an X-ray abdomen showing us that serious colonic stool retention is present. It can be done either orally or it can be done from below, either from above or below. जब बहुत ट्रैफिक जैम हो जाता है तो ऊपर का काम नहीं करता है तो नीचे से करना पड़ता है. That is how I explain to them. Now this is exactly I use the words in the clinic. I think this would help you guys if you're trying to manage these children in the clinic. And all the best if you're doing. Hospitalization very rarely is required. Most of the time we can do it on a domiciliary basis, but sometimes there are non-responders because they don't take the treatment as you tell them, or they are not responding. They're severely bunged up, severely constipated. So they need to get hospitalized. Sometimes, very, very rarely, we have done a manual evacuation. Usually that's accompanied with a rectal biopsy and a sphincter stretching. These are the two things combined, all three combined together for disimpaction. Now, how would one disimpact with oral medication? Usually polyethylene glycol without electrolytes. What I use is Easylax, EZLAX. We'll come to the trade names later. There's only one slide with most of the trade names. I'm sorry for that, but these are only 5 drugs which I use. So I don't know anything more than that. Sorry. Then there is polyethylene glycol with electrolytes. That's a 2-liter solution that we make, 2 liter पानी में ये पूरा powder डालने का, बारी-बारी करके पीने का. It's like having a meal after meal of water. Most of the time the children tend to throw out. So polyethylene glycol with electrolytes, that solution of 1 liter per ml per hour cannot be given without an esogastric tube blast. No one can drink it. No children can drink it. Then we have mineral oil, lactulose for the acute phase. That is Sena and bisacodyl. These are stimulant laxatives, can be useful. I do use them sometimes. Rectal medications for disimpaction. From below, what we have available is the phosphate enemas. The smaller size we have is the neotomic enema, and the larger size we have is a proctoclise enema. Neotomic is 20 ml. I would usually use it in a smaller children and a small toddlers. The older children would have a phosphate enema. Phosphate enema, proctoclise enema is a 100 ml enema that we have. it not used in renal insufficiency. Another important thing when you give an enema is you can't direct it. Sometimes they say, Doctor साहब हम तो दिया enema लेकिन पूरा का पूरा पानी ऐसे ही आता है, because they're hitting against the wall. There's a nice mass there hidden inside the rectum, and you're putting the enema onto the rectal mass. So what you have to do is you direct backwards towards the back. So it goes between the mass and the rectal wall, and then it comes out. These are small tricks which I've seen and the problems which I've seen practically happening. Sometimes we use suppositories, glycerin suppository and Delcolax, that bisacodyl suppositories. Mineral oil enemas are also seen, used sometimes for retention to soften the hard stools, and then give an evacuant enema after 6 to 8 hours. That is the phosphate enema. First give a mineral oil enema and then give an evacuant enema. These are sometimes tried. Laxatives. They usually work, the oral medications work better after the clearing happens completely. The traffic jam is cleared, then the policeman will work better. That's how exactly it happens all the time, even on our roads. Osmotic laxatives are preferred. What are osmotic laxatives? Polyethylene glycol, then lactulose, milk of magnesia. Mineral oil is a surfactant laxative. The stimulants like senna and bisacodyl, that Delcolax and Picolax, we are not really interested in very routinely, and regular maintenance. This is just the list. It's a complex list. I don't think we need to, we just need to go know the name, which we already discussed. Polyethylene glycol, lactulose, sorbitol, mineral oil, magnesium hydroxide, magnesium citrate. These are osmotic and surface acting, lubricant. Then there's stimulant, which is senna and bisacodyl, that is Delcolax. And we have glycerin suppositories. Now, how I do it? Very simple. First of all, to dislodge the hard feces, enemas are required. Either you do proctoclise in older child or neotomic. I usually start alternate day. I would say continue for 3 days, 3 turns, 5 turns, 10 turns, depending on how badly constipated he is. Or I would advise in some intelligent parents that till the returning stool is soft, you keep continuing alternate day. That works usually. And I would put the child on gut clear. Gut clear is a osmotic laxative. This is the only slide that has got trade names, fortunately or unfortunately, because these are the only drugs I know which I use in constipation. Gut clear is basically osmotic laxative where the volume is less than Delcolax. The Dufalac, Dufalac, the volume is very high. It's about 2.5 ml per kg. For a 10 kg child, you may have to give 25 ml. 25 ml is like a mega meal, I think, sometimes. So gut clear because the volumes are less. And Isilac sachet is the polyethylene glycol without the electrolytes. So that is, you dissolve in water and give it. These are the 2 things I would start. Gradually, once he's clearing off and the enemas have stopped, I would discontinue Isilax in 3 to 4 weeks time and just continue with gut clear. That is how I would use. Most of them, almost 95 to 98% would respond. Some would not. Then I would add Picolax. Picolax is basically sodium picosulfate. It's a stimulant, and potassium citrate, which is an osmotic. It's a good combination. Again, the volume is less and good efficiency, but it is a pretty strong for children sometimes. So Picolax only in children which do not respond. Dufalac is also one of the favorite ones for most of us, but the volumes are pretty high. But Dufalac is as good as gut clear. So I think either of them would be good. That's how I would do it. And maintenance would be with gut clear most of the time, till he's okay, until we kind of get better with the constipation. What is the role of suppositories? If you ask me, almost nothing. The suppositories available in the market for constipation is glycerin and bisacodyl. And see, suppositories basically cannot help disimpaction and cannot help maintenance either. So it's of no use basically. Sometimes it may be of useful in smaller children, especially glycerin suppositories, and when relapses happen subsequently. That's when I use these suppositories. There are some new pharmacological agents, but for pediatric age group, they are yet not available, approved by your US FDA. I don't know their names also. I've never used them, never seen them. Behavior modification is one of the most important things. Toilet sitting. This is a good nomenclature. I got it. I never heard about this nomenclature. When I was reading for this topic, toilet sitting. The child needs to, I advised them, but I didn't know I could use this toilet sitting. The child needs to go to the potty seat fixed time in the day for 5 to 10 minutes. Whether he passes or he doesn't pass. You have to just sit there. Maybe do whatever he wants, maybe read a comic or play on the iPad, avoid distraction. But as far as possible, let him sit first with distraction, then remove the distraction that is there. Then reward system should be provided. Even for an effort of going to the toilet and sitting, one should give reward, not for passing stools only. That is what. And monitoring a diary is important. The logbook. When did he pass? When did he sit? Was it associated with pain? Was there bleeding? What is the consistency of stools? All those things we need to maintain a diary. Dietary changes we have almost taken care of. Fiber intake. We discussed what stop bottle feed. Maida products have to go down. Exclusive milk diet needs to go down completely and increase fiber intake. What has helped me in toddlers sometimes is making shots of dry fruits like figs and khajur and raisins. Make a mixie, make a nice little shots with milk. The children who like sweet, have a sweet tooth are very happy to have those shots. So that gives a lot of fiber. That's what I tell the mothers sometimes. This is a good shot, potent way to, sometimes green eating. You can't be Popeye. Everybody cannot be Popeye eating spinach all the time. Most of the children are not happy eating spinach. So it is difficult to kind of give direct greens to them. But you can supplement them in the dal, in the soup, in the flour with which you make the chapatis or the parathas. This way you can mask them so that the children fiber intake increases. Use of probiotics. There is no controlled trial having proof that probiotics are useful in constipation. As we know, the treatment failure is almost 25%. Why would it fail? Either you not educated them well or the treatment components are not adequate. That is our problem. Then there's inadequate medication. That is also our problem. Then premature discontinuation. They may discontinue themselves also. The poor adherence to the program, that can cause failures. And if the failure happens once, twice, thrice, then you have to see and go back that whether the diagnosis that you made of functional constipation is right or is the problem. As we discussed earlier, it may be months or years. And passage of one stool per day, or at least one stool in 2 days, soft and regularly, is the ideal situation one wants to be in. What is the role of surgery in functional constipation? As I told you earlier, manual evacuation of feces. Unfortunately, a surgeon giving you only one surgical slide in the entire talk. This is the slide. Rectal biopsy to rule out Hirschsprung's disease. Then anal sphincter release can be helpful, sometimes in a fissure, acute spasm. You can inject botulinum, Botox. You can do a myectomy or a sphincterectomy or just stretching of the sphincter. Then in neurological spinal deformities, myelomeningocele, antegrade continent enema, we take the appendix out, get it out on the abdominal wall so that the parents can put in a tube and give antegrade enema, not enema from below, but enema from the ascending colon downwards. That is called ACE procedure. And the other surgeries are colostomy, ileostomy, and resections. There's something known as a non-retentive fecal incontinence, where there is no retention, but there is yet incontinence. Usually this is because of the slow movers, the slow transit time. Behavioral modifications, psychological support, and laxatives are also useful in that. As we all want a happy ending, but fortunately or unfortunately, we don't have such a happy ending when we're dealing with functional constipation. Thank you for your kind attention. I'm ready and happy to take any questions if required.
Thank you, Dr. Rakesh. That was a wonderful talk on a topic which is quite sensitive and very difficult to deal with for not only the doctors but parents and the child themselves. So kindly put down your questions in the chat box, or if anyone has any questions, they can let me know so that we can ask directly. There was one question which was there in the chat box, and that was for a topic which you said you won't discuss much in your talk, and that was for Hirschsprungs. So
Yeah,
they
what
have
was the
asked
question? I
what,
can answer the question, but the
yeah.
topic, Hirschsprung
So,
itself is a huge topic to really
yes, so they
discuss.
have asked what are the tests for Hirschsprungs?
Yeah, 4-5 tests: clinical, history, examination. I had already told you, plain X-ray abdomen. The X-ray that we saw showed us a lot of loading of the feces in the rectum. In Hirschsprung, there will be no pelvic gas at all. The pelvic gas will be absent. Barium enema is a diagnosis. Then rectal anometry, we have already discussed. That is another way to diagnose. And finally, a rectal biopsy. These are the 5-6 ways in which you can diagnose Hirschsprung's disease. Rectal biopsy is 100% foolproof. Yes, no. Most often.
All
Sir,
right.
what is the incidence of anal fissure in kids?
Oh, pretty high, very high. It is as much as what you see in adults. Only thing is, I don't try and dig in. See, once you know that there is habitual constipation and there is painful defecation, they're most likely to be an anal fissure. That's why he's got pain. Otherwise, there won't be any pain. So I don't really dig in. I try and just open up the cheeks. I never do a PR for that reason. You know, if there's painful anus and you do a PR, it's just going to freak the child out and the parents out. So you just open up the cheeks and see if you can obviously see a fissure. But you have to treat it as a fissure. But fissure is treated not by local application, as I told you. It is treated by treating constipation and sitz bath. Sometimes surgical intervention in the form of sphincterotomy may be required, very rarely.
Does local application of nepilepine or diltiazem help in kids?
I see the local application is always also very fretful for the child. You don't understand. When you give enemas also, I don't know how often you have dealt with. When you take an enema, the child gets fretful of anybody coming close to him, or even flexing the hip. The child gets so scared that local application is a complete no-no, according to me. It's just going to worsen the situation. The pain can be taken care of with dealing with the constipation better than local.
Thank you. Thank you, sir.
There's another question from Dr. Sheila Kulkarni. She asked, what is the incidence of hemorrhoids in the pediatric age group?
Oh, extremely rare, Sheilaji. Extremely. I have yet to see. I have seen 1 or 2 in my lifetime, and that is all secondary to portal hypertension. Hemorrhoids in children is completely not a diagnosis. Sometimes we do see, because of constipation, external hemorrhoids, not the internal hemorrhoids, but externally you see 3 blobs because of excessive chronic constipation. But it is not very common. Internal hemorrhoids is almost unheard of, unless you have portal hypertension.
All right. Till we wait for a few more questions, I'll just ask a few questions to you, sir. A lot of people talk about early toilet training and things like that can lead to constipation. What is your thought on that?
Agreed. As I told you, that toilet training should be only done when the child is ready. And who decides the child is ready? The caregivers. We as doctors need to take the call that, okay, ready or not ready. And intelligent parents should also know. And nothing before 2.5 years, I think I would at least 22 months to 30 months is an average time one should start. It will take 4 years also to kind of completely train.
Another question is, as per your specialist opinion, is there a right time or any red flag that you would tell our family physicians to catch before, so that they can send you a patient in time, or even for a parent, like when should they actually seek help after trying all these other things?
I think during the time of moments of truth, as we discussed earlier, these are the times where you kind of can slip very badly. So the earliest you slip, it's like a recent onset constipation is always easier to treat. Now you treat the same thing after 6 months or 1 year, it's that much more difficult for all of it, doctors, child, and the parents and the family. So the recent onset is always better. So the moments of truth is the time when you have to be very vigilant and catch them catch them young. Okay.
So,
I
and
hope that answers your question.
you spoke about even prevention. Other than just the diet and things, is there anything else the family members or people can do to help prevent these issues?
Yes, one should be vigilant. What kind of stools mother has to see? Whether stools are hard, getting harder, is he getting pain, discomfort? The moment the earliest signs, they should take the remedial measures for whatever cause they feel is causing the whole thing, or take necessary doctor's advice. The doctor will be able to advise them better. But the earlier you start, the earlier you catch them, the better it is. That's all.
All right. So there's another question regarding Dufalac and Isabgol causing bloating in children, and like how do you deal with it? Do you recommend it when treating?
Agreed. I completely agree with this question. Dufalac, then Isabgol, and especially the not Peglac, but polyethylene glycol. That Easylax, that causes lot of bloating. That's why the volumes are very high. That is another reason. You can't have some 50, 70 by 100 ml of fluid the child needs to drink at one go. It's impossible. Yeah? I think even we cannot probably sometimes, because it's not palatable. It's difficult to. That's why I give medications which require smaller doses. Like gut clear, the dose is almost 1/3 of Dufalac. Oh, that's why. And even sometimes the synagogue and the Picolex, where the volumes are smaller. Yes, those.
Sir, any IBS is common in children?
Sorry, inflammatory bowel disease.
IBS.
Yeah, I did not definitely. I did not touch upon that at all, because now, especially the adolescent age group, we see a lot of them, because most of it is psychogenic, as we know. It's not. It's most of it is functional. And this Rome 4 criteria, there's a separate criteria for IBS. If you see, the Rome criteria has given the Rome 4 for constipation in adults is different, for constipation in children different, and IBS. But children IBS is now noticed in especially the adolescent age group. The smaller ones, I don't think we should bother about IBS as a diagnosis.
So there's another question, as you spoke about bloating caused by Isabgol. So the question is like, should we be using Isabgol in children? Is it safe for children, or?
Isabgol is a very safe laxative, completely safe. If the children is able to tolerate and have it, you can't have a natural fiber like Isabgol. It's a natural fiber. It's like when you increase fiber diet, Isabgol is one of them.
All right. So that is it from the questions from the participants. Does anyone have any more questions if they would like to ask? All right.
Sir, can you tell us the syrup you advise for constipation other than Dufalac you had said?
Gut clear.
Huh?
Gut clear. It's a trade name, sorry. GUTCLEAR. Gut
Okay.
clear.
Thank you, sir.
The volume is less. It's lactylol. It is not lactulose, but it is lactylol. It is different form of osmotic diuretic. Osmotic laxative, sorry.
It works in adults also, sir?
It does.
Okay.
It does.
Okay.
But
Thank
it's
you,
in
sir.
the syrup form. Yeah. Syrup gut clear is what I use. So
Okay.
I don't know if tablets are available. I know only 5 or 6 medications. Sorry, I'm a surgeon.
No, that's okay. Thank you, sir.
All right, so I see there are no more questions. Thank you, sir, for that excellent talk. And with your depictions, you have hopefully made poop more clear for everyone so that they can help children to push the poop. Thank you so much, sir.
Push that pool.
Push that poop. Yes. Thank you. And now moving on, I'd like to welcome our next speaker, Dr. Sagar Warankar. He's a pediatric pulmonologist, and he has vast experience in treating pediatric allergies, asthma, bronchoscopy, pulmonary function test, and a variety of respiratory diseases. And he's again going to be talking about an important condition for allergic diseases and ghost diagnosis. Dr. Sagar.
Hello. Yeah, can you hear me?
Yes, you're audible.
Yeah. So thank you so much, Avi. And I think I'm the last speaker, and it's already 4:30. Extensively, both the prior speaker have covered their topic. So let me do some interesting way. So I thought I will do some case presentation in these scenarios. So my today's topic is allergic rhinitis ghost diagnosis. What exactly it is meaning? So the way the ghost is somewhere hidden, so same way the allergic rhinitis is somewhere hidden in our diagnosis. So most of the doctors are they're not able to diagnose the allergic rhinitis, and they're missing this diagnosis, and that's the reason a lot of children, adolescent guys, and as well as adults are suffering because of this allergic rhinitis, because it's a hidden disease. So let's see how it is hidden and why we are not able to diagnose it. So here is one case number one. The 4-year-old Master A. He has frequent colds and coughs. Cough is very dry, more at night, with variable periods of cough, free intervals also. So intermittently, he's absolutely all right. Episodes seldom associated with fever. There is no snoring or mouth breathing. There is no history of wheezing in the child, but father is known asthmatic. This child rubs his nose and sneezes often with persistence of nasal symptoms. And on examination, his growth is normal, development is normal. Systemic examination had some amount of atopic dermatitis. Ear, nose, throat exam shows erythema but no bulge in ear drum. Nasal congestion with clear fluid, and throat is little bit of congested. The child with increased frequency. So, what are the points to be noted? The child with increased frequency of symptoms at one or point at the contagious anatomical site, like nasal, pharyngotonsillar, ear, laryngeal. Some children they are frequently they do very often this sound. Some do. So these are the some symptoms or signs which you can pick up as a doctor. There is a temporary stuttering of growth and development in some children because of frequent episodes of cold and cough, more frequent disturbances of appetite, sleep activity. So these are the some occasional red flags and that need to be elicited in the children. So this child, if you see, he had moderate to severe allergic rhinitis because he's been suffering every alternate day. There is another case. He's an adolescent boy, 12-year-old boy, presented with history of breathing difficulty, cough, and fever for last 2 days, and past history of two similar episodes in last 6 months given by mother. His physical examination had high fever. There was chest wall indrawing, hypoxemia, SpO2 of only 88% in room air, unable to speak in sentences. So there is a very much of respiratory distress in child. So he's in acute respiratory distress. On admission, his temperature was 38 degree, RR of 34 per minute, which was high for 12-year-old boy. His pulses were 106 beats per minute and saturation, as I mentioned, 88 without oxygen. So what is your probable diagnosis? So everybody knows. So because this is the first kind of episode you as a doctor seeing, so we think that it's either Valdry, I mean the V's associated lower respiratory tract infection, or it could be acute asthma with viral fever. We don't know the past. Now, if with the history, if you see the past history, he in the childhood until 5 to 6 years of age, he had frequent episodes of cough, cold, for which he used to take frequent nebulization. Later, he was all right until 6 months back. What happened 6 months back? He had one first episode of severe wheeze. But in between these episodes, he's having sneezing early morning and stuffy nose. But other than that, no wheezing, no breathlessness, but only sneezing and stuffy nose intermittently, which he is because he's adolescent boy, so he's not bothered about it. So he's not. He never communicated with his parents as well as communicated with his doctor also. On inquiry, later found to have some building work going on in his school since last 7 months. So this is the typical case of partially controlled asthma with severe allergic rhinitis. So third case, 7-year-old girl with snoring, cough, constant mouth breathing, and frequent episodes of upper respiratory tract infection was referred to an ENT clinic to evaluate for the adenoidectomy. Parents reported there is a history of 2-year constant nasal blockage associated with frequent colds, which had worsened over the time. She also had bouts of sneezing attacks, and that were more frequent in rainy and winter season. So there is a seasonal variation in the child. Family history of atopy: her dad had asthma and mom had allergic rhinitis. On examination, she's a chronic mouth breather. So what happens? They are always keeping their mouth. The children, they will have always, nowadays they are putting masks, so you're not able to see, but you can just remove the mask and see the faces. You will see the mouth is like this, and they're anxious on their faces. The face becomes a little bit elongated, and you can see the inner teeth easily, and that is how you can see that you can say that there is a chronic mouth breathing going in this child, with pronounced allergic shyness, blocked nose with large inferior terminates, and she had grade 2 tonsils with few expiratory wheezes on auscultation. Her flexible nasal endoscopy showed an enlarged adenoidal pad in nasopharynx. So they came to me. I examined everything and I saw this child is suffering from something like allergic rhinitis. So I did the allergic prick test, which showed house dust mite 8 mm and gross pollen of 4 mm. Her forced expiratory volume at 1 second was 62%, which is very, very low. It should be minimum more than 80 to 90%. So what is the probable diagnosis in the child? So this is the child with allergic rhinitis with enlarged adenoids. Another case, 3.5 years with recurrent episode of noisy breathing, increasing intensity with cold. In between colds, very minimal noisy breathing is there, still present. 15 days in month, he is having sneezing and running nose. 4 times admitted so far. Child is not thriving well. He is only 9 kg at 3.5 years of age. So there is a growth failure. Developmentally, gross motor delay is there, mild. On examination, watery rhinorrhea, inferior terminates are pale. Head to toe examination, there is a suprasternal retraction and this type of sound, that is inspiratory strider sound present. So on inquiry, if there is a noise more than cough, consider Malaysia syndrome in early age. So he's a big boy, but still he's having something like a stridor. So Malaysia syndrome worsening with allergic rhinitis was the diagnosis. So this is nothing but laryngomalacia in the child, which was there, but it has reduced as compared to previously. So with this, if you see all these 4 cases, they are presenting with some amount of like asthma or some other presentation, but there is underlying allergic rhinitis, which we tend to forget and we don't ask them because we are more worried about his cough or that their cough, and that is where we are. So what will be the overview of my talk? So you will see how what exactly is the understanding of allergy, how will you diagnose it, what is the exact atopic march, and pharmacotherapy. So allergy is nothing but a chronic condition involving an abnormal reaction to an ordinary harmless substance. So I tell my patients, it is nothing but nonsense response to nonsense thing. Doctor, हाँ, yes, you are right. थोड़ा भी स्प्रे मारा या फिर पाउडर लगाया तो इसको छींके आना चालू हो जाता है. Whenever we put some good night coil or something like that, he starts sneezing and he gets irritated, and then that night he's about to cough and he will cough and then night is gone for him as well as me. So that's what I say, it's nonsense response to nonsense thing. So normal people don't behave the same way, but allergic people behave something different way, that is called as nonsense response. So allergies are also known as Ig mediated type 1 hypersensitivity reaction. This can be because of skin contact, it could be because of injection and inhalation, we'll see. So that's what I said, an allergy is response to body's immune system. So most of them come to me, नहीं इसका ना डॉक्टर साहब इम्यूनिटी है ना बहुत वीक है, इसकी वजह से इसको बहुत एलर्जी, इसको ये तकलीफ हो रहा है. But mind it, my dear friends and my seniors, that allergy is nothing but it's not your poor immunity. It is in fact a very, very robust immunity. These children will have very good immunity, and that's why they over respond to this, and that is allergy. So allergy is not poor immunity. Allergy is in fact a normal immunity, but responding to abnormally to nonsense things. So never tell your patients or parents that your child is having weak immunity and that's why he's having allergy. No, it's not like that. It's actually opposite. So if you see Gel and Coombs classification, it's Ig mediated type 1 hypersensitivity reaction and different, but we see drug allergy as a type 4 also. So we're not going to talk about that. So pathophysiology, it's very simple. I just wanted to highlight. So when allergens comes to your body, they come to in contact with the macrophage, and macrophage captures them. And what happens? These macrophages, with some amount of chemical reaction inside the macrophages, these allergens come to the surface of the macrophages, and these macrophages with the allergens get in connection with the T lymphocyte. So T lymphocyte is the most important cell in the allergen response to anybody's life. That it is the main orchestral cell, I would say, and it recognizes the allergens thanks to the specific receptor. It memorizes the antigen allergen identity, and what happens? It gets connected to the B lymphocyte, and after getting connected with the B lymphocyte, this T lymphocyte passes the information about the allergen to the B lymphocyte, and then this B lymphocyte converts itself into the plasma cell. From the plasma cells, it produces Ig for the allergen, and these allergens, Ig gets released soon in as they are produced, and then this Ig bind to the surface of mast cells in the blood, and they're ready for the future attack of the allergen. Whenever there is a future attack of subsequent contact of that allergen, this allergen gets connected with this mast cell bind to the Ig bind to the mast cells and get complex and causes histamine release in the body, and you see the varied presentation of the allergy like atopic dermatitis, allergic rhinitis, and of course allergic asthma. So if you see the important cells in allergy is not epithelial, goblet, dendritic, it's the T lymphocyte. That's why it's called as the brains of immune system. And if you see the definition, what is most of the parents and doctors have the question, what is allergy and what is atopy? So atopy is nothing but the proneness of allergy, but that doesn't mean this child is allergic to something. So he is having that genetic tendency to develop allergic disease, but that doesn't mean that he will have allergic manifestation. So it is a genetic, what we say, it's a genetic composition, and allergy is nothing but phenotypic presentation, what you see in your clinical practice. So it initially have atopic dermatitis, then allergic rhinitis, and could have asthma also. So atopy is typically associated with heightened immune response to common allergens. So that's what I said. इसका immunity कम नहीं है, इसका immunity बहुत अच्छा है, but वो proper response नहीं दे रहा है. So that is what is very, very important. So most commonly asked, that's why I kept this slide, that डॉक्टर मुझे एलर्जी नहीं है, मेरी वाइफ को एलर्जी है, मेरे हस्बैंड को. सो दे स्टार्ट ब्लेमिंग ईच अदर. इसके घर साइड में है, इसके घर साइड में. सो यू हैव टू टेल देम, सर, it is not just only the family history of allergies is important. What is important is if mom and dad both are allergic, then the chances of developing only 5 to 15%. So what exactly? So there comes your epigenetics into the play. So irrespective whether mom and dad is allergic, that doesn't mean, but even if they are not allergic, the 5 to 15% chances, but one sibling is allergic, then it goes to 20 to 40%. If mom and dad both allergic, it goes to 20 to 40. So but remaining 60% is very, very, very important. That 60% comes from your epigenetics, your environmental, and how you are food wise, the environment wise you are grown. So clinical picture of allergy, if you see, it could be allergic rhinitis, chronic rhinosinusitis, sometimes conjunctivitis in eyes, and some causes that obstructive bronchitis or wheezy bronchitis, you name anything, doesn't matter. So skin wise atopic dermatitis, contact eczema, you have urticaria, you have exfoliative dermatitis, you have seborrheic eczema. And of course, nowadays, as Rakesh sir has already mentioned, I have seen a lot of children with allergy coming with severe constipation. They're coming with gastrointestinal symptoms like IBS like presentation, like irritable bowel syndrome like presentation. And of course, constipation is on higher rise nowadays. So what exactly is the concept of allergy? If you see, there is a allergic march that I'll come to that in next slide. But there is a concept called polysensitization, and of course the cross reactivity also. So what is polysensitization? Is nothing but you are sensitive to two to three different kinds of, like, pollens or something like fungi or molds, different. So it's not only one sensitization, but you're sensitized to different allergens. So that is called as polysensitization, and it's possible. But if you treat one, automatically the other gets better. And there is something like cross reactivity. Some patients are they are prone for, or they are allergic to the. If you do allergy skin testing, they show the allergic to the grass or weeds, but there is a cross reactivity. So some grass pollen, they have a banana cross reactivity, some has melon cross reactivity like cynodon, and all these are having cross reactivity. So if you stop one, automatically the other gets better. So if you see the atopic march, nothing but initial period, in infancy, the children. So in history, you have to ask the child who present to you as wheezy asthma or allergic rhinitis. If you ask them, they will definitely have eczema, almost 70% in the children in first year of life, and it is almost 70%. But they outgrow as the age progresses. This eczema gets better by 1 to 2 years, almost 70%. 30% remains lifelong and becomes eczema. So that is why it is called as allergic eczema. Is often the first step of allergic march. And of course, food allergies, 80% patients will outgrow. So food allergies like milk, cow's milk, or some nut allergy could be present in early years, but it can be outgrow after age of 2 years or 3 years. And of course, seasonal allergies, and then it goes into the asthma. So it is nothing but the play of your Th1 and Th2 paradigm. So the allergic people will have more towards the Th2 pathway as compared to the non-allergic person. So if you see, as I mentioned just now, the initial period, the patient will have atopic dermatitis. It goes in initial period, and then comes to your food allergy in infancy. Once that food allergy goes down, and your atopic dermatitis come down, and then your allergic rhinitis starts increasing, then your asthma increases, and then it becomes plateau. Allergic rhinitis remain forever, but asthma sometimes, not asthma, I would say multi-trigger wheezer or something like episodic wheezer. They will have wheezing until 5 months, 5 years of age, and it can come down. But if you don't treat them, sometimes the percentage, because of environmental pollution and other things, the percentage can go higher. So what is important is to treat early. So value of early identification of allergy symptoms are very important. If you treat the child when he has got eczema, the early diagnosis intervention in the form of the food changes, the lifestyle changes, and integrated treatment with allergy finding after 2 years of age, then you can definitely stop the progression from eczema to rhinitis, and from rhinitis to the asthma. So the important now is the quality of life and stop the progression. That is the motto. So as I said, polysensitization. If you see this photograph, the dust mite will be there all the time. So most of the time, I get question from in conferences and in lectures. The doctor, we know that there is a dust mite allergies present in all our most of our patients. So why do we need allergy skin testing? So this is the diagram which shows that dust mite will be there forever for most of them, almost 80 to 90% of our Indian population, at least in Mumbai region, definitely, because we have hot and humid condition. And of course, but we have molds around also. And of course, in between we have birch pollen, we have ragweed pollen. So why it is important to know the allergies which is present in that particular patient? As I said, cross reactivity as well as polysensitization. Suppose we know that this patient in between April, May, June is going to have symptoms, or he is having symptoms in the winter month, then we know he's suffering something related to other than just dust mite or molds. There is something like pollen allergy or molds allergy also. And in these children, we can have allergy vaccines, but now we don't inject, so we can give immunotherapy to the children by treating their dust mite. So base level of their dust mite and mold coverage. So if you see the burden in India, it is huge. Almost 20 to 30% of Indian populations suffers from at least one type of allergic diseases. Allergic burdens almost 40 current in India, and I see a lot of patients due to lockdown effect. Maybe they are staying at home, a lot of dust mite at home, and the children are less exposed to the sunlight nowadays. They're less exposed to the they're not playing they're not playing so physical activities, their immunity is little bit haywire, and I'm seeing a lot of patients coming to me with allergic rhinitis as well as different types. So what is the that is why it is very important to know the hidden thing, that is allergic rhinitis. Most of the time they don't present with you, because most of the time they present as a nasal blockage, but they don't complain. So we have to find out why this asthma is not getting better, why the child is suffering every month he's coming to you. Need to find out just that by saying no child chota hai na, abhi sardi khasi chalta rehta hai, but why he's suffering every month? That should not happen every time. So as I said, allergic rhinitis can lead to bronchial appendix. So that's why it is called as united airway disease. So this is the beautiful study presented in Lancet. What it shows is that allergic rhinitis, what they have done is atopic, the patient with no rhinitis and with allergic rhinitis, what they have found, the patient who had allergic rhinitis in patients with bronchial hyperactivity, in future they followed until 8 years of age, found to have asthma prediction of 4%. So those who didn't have allergic rhinitis, only 1% had asthma after 8 years of follow-up. Those who had allergic rhinitis, they had asthma of 4. So almost 4 times, is not less. So let's come to the allergic rhinitis perspective. Allergic rhinitis is nothing but most common clinical expression of atopic hypersensitivity. So there is a ARIA classification of allergic rhinitis. So anybody who is less than 4 days per week, so it's not necessary we should have daily symptoms. Even if 1 or 2 days per week symptom of cold, sneezing, rubbing on nose, irritation in the morning, nasal blockage at night, less than 4 weeks is called as intermittent. And persistent is severe, that is more than 4 days per week, or and more than 4 weeks. And mild is variety and moderate to severe. It depends on the, so most important is how many days he's suffering in a week and how many weeks he's suffering. And then mild variety, whether is it causing any impairment his daily activity, sports, leisure, whether it is having hampering his normal work or school, or is there any troublesome symptoms, like because of allergic rhinitis, whether he's having cough, he's having allergic symptoms in the throat. Most of the patient comes to me, doctor कुछ ना कुछ इसके गले में अटका हुआ रहता है. So that is nothing but post nasal drip. अभी हमेशा ये है ना, ऐसा कुछ ना कुछ ऐसा करते रहते हैं, रात में भी दिन में भी, एंड कभी कभी ना बीच बीच में ऐसा मुंह से सांस लेता रहता है. So I don't know what is happening to him. I think he's having some problem in his chest. The problem is not in the chest, problem is in his nose. So try to find out what exactly, how he's breathing. And nowadays we have the mobile camera. So I tell my patient, अब आज से ना थोड़ा सा you start looking at your child and observe the child with these symptoms. रात में कैसा है, दिन में हाइपर एक्टिविटी बढ़ गया है क्या उसका, या फिर बहुत शांत शांत तो नहीं रहता है, बट हाइपर एक्टिविटी ज्यादा बढ़ गया है, या फिर ही इज नॉट कॉन्सेंट्रेटिंग व्हाइल स्टडिंग. वैसे भी आजकल पेशेंट बच्चे कॉन्सेंट्रेट नहीं कर पा रहे, बिकॉज they are always on the most of them are their schools are on mobile or laptop, so they are not able to concentrate for prolonged. Maybe because of allergic rhinoconjunctivitis also, they are getting irritation in their eyes. So because laptop, mobile, you have to see from the very less distance as compared to television, so it's very difficult for them, and they are not able to complain. And then will be watering of eyes. You go to doctor, the eye specialist, they say there is no problem in eyes, but still child is not able to concentrate. The reason being the allergic rhinoconjunctivitis. So don't miss it. So relevant history is very important. Like the personal and family history is very important, like lifestyle, hygiene, cesarean delivery or prematurity is very important. You have to know the family history of atopy. Area of residence is very important. There is a beautiful study in Japan. They did what they found is the patient, children who are staying near to highways as compared to the children who are residing 500 meters away from the highways or main road. I would say in Mumbai we don't have highways, but yes, of course we have the big roads. So where big diesel cars or diesel motors are, every time they're passing. Or so what happens, because of this diesel combustion in the air, there will be lot of these diesel particles, and that can cause your allergic rhinitis per se. And of course lifestyle and hygiene, more the westernized food culture, the more chances of allergic diseases in the children as well as in adults. So living near heavy traffic area, that is very important. एनवायरमेंटल टोबैको स्मोक, नहीं डॉक्टर हमारे घर में तो कोई स्मोकिंग नहीं करता है, घर में तो कोई नहीं करता है, लेकिन आपके बालकनी में तो कोई करता रहेगा, या फिर आपके मोस्ट ऑफ द हाउसेस नाउ आर like housing societies, they have residents from the first floor, and down there is a shop. So what happens, below the residences, shops will have something like tea, coffee shops, and most of them will have smoking over there, or some amount, somebody will be smoking it, and that smell can come to your house, and that is very dangerous. Of course burning mosquito coils is very very common, is what I see. The and bio cooking fuel has come down as compared to, but I see patients from like Bhiwandi and those areas, they come to me with bio cooking fuel and dung cakes and agriculture waste and firewood, and that is why Delhi suffers a lot during these winter months. So let's see what are the signs of allergic rhinitis with which you can find out, like allergic shyness, allergic line. So here the allergic shyness. Thank you, Dr. K. Nagaraju, for giving me these pictures. This is nothing but allergic shyness. You can see this line there, bluish black discoloration under the lower lid. नहीं आजकल वो टीवी ज्यादा देखते हैं ना, उसकी वजह से है. आजकल वो मोबाइल ज्यादा, so we are just putting some label and we are not seeing. And they are caused by pressure on veins by edematous allergic mucous membrane in the nasal and paranasal cavities. As of course we see the allergic line also, this dark line between the cartilage and bony septum. It is because of children doing like this. That is called as allergic salutes. And of course they do allergic mannerism, but very very less when they come to you. And the Denny Morgan line, which is beautifully depicted here, that is because of eyelid Mueller muscle spasm. And this is typical allergy salute, or like this or like this. So this is definitely an allergic prone patient. And this is the Darrier line. There is a lateral crease developed due to constant itching on rubbing of nose in upward direction. So this is nothing but Darrier's transverse line. This is what I was talking. So due to nasal block, mouth breathing, you see the allergic gape, which is very common. Long eyelashes due to venous stasis, and watering of eyes due to blockage of nasolacrimal duct. And examination, if you see the examination per se, nasal mucosa, you see the terminates hypertrophy. I'll show you the photograph also, and you could see the polyps sometimes, but very rare. मिडल ईयर पैथोलॉजी कुड पॉसिबली, डॉक्टर है ना, कान में भी इसको ईचिंग होता रहता है, बार बार खुजाता रहता है इसको. जब से इसको सर्दी का तकलीफ है तब से कान में खुजली करता है. सो दैट इज वेरी वेरी इंपॉर्टेंट. एंड ऑफ कोर्स नेक, sometimes you have frequent rhinosinusitis and causes lymphadenopathy. You have skin atopic dermatitis. You have to see that cobalt stoning of oropharynx. You see patches. If you tell them you see the lymphoid hypertrophy, and you see the cobalt stoning of and red oropharynx also. So this is typical of cobalt stoning. You can see here you have this inferior turbinate hypertrophy. You have lymphoid hypertrophy can be seen. So these are not a good tonsillar hypertrophy can be seen. And of course flagellar dermatitis, atopic eczema, and urticaria could be the other allergic rhines. So why it is important? Why you are talking about so much fuss about allergic rhinitis? Mind it hampers your quality of life. It can go into asthma. It can go into conjunctivitis, sinusitis, frequent sinusitis, polyposis, and of course upper respiratory tract infection. Or now there is one another terminology called sinobronchial syndrome. What happens? The children, when because they have post nasal drip, when they lie down they start coughing, and this sinus dripping goes inside the child lung, and you see most of the adolescent they will have coughing at night, and the right middle right main bronchus ending, you see lot of fluffy infiltrates, and that could be given as a um, middle lobe pneumonia or something like that. Don't treat it, it is nothing but see to the nose. So it is very important. And secondary, it causes your quality of life, it causes sleeping disorder. I see a lot of because I do sleep studies, so lot of sleep disorders patient because of allergic rhinitis, and of course comorbidities like sinusitis, and of course they have learning and attention impairment, and they have hyperactivity disorder. They don't sit at home at one place. um, they do because of allergic rhinitis and because of obstructive sleep apneas. These patients will present to us, most of them come to me in very very late stage, and what happens, they have bladder hyperactivity also, they are constipated also, and of course learning difficulty impairment is very common, and mouth breathing and dental malocclusion. So, as I said, it's a one airway disease. If you don't treat allergic rhinitis, of course, you will have asthma in future, definitely. So, if you see the proposition as it's a one airway disease, I will not go into detail. The same anatomical mucosa present in nasal as well as bronchial, and that's why it's nothing but ciliated pseudostratified columnar epithelium. Of course, pathophysiology, the vasculature of terminate, bronchial challenge, the inflammatory cytokines are all ever same. So you see the early and late phase responses also. Treatment, if you treat allergic rhinitis with leukotriene antagonist or with the corticosteroid in a nasal spray, of course your asthma gets better. Sometimes if you just treat for asthma with budesonide inhaler, your allergic rhinitis get better. And of course immunotherapy down regulates inflammation throughout the respiratory tract. So this study also mentions that what it mentioned, that if you treat only asthma, so requirement of medication is very important. What they have seen is doctor diagnose asthma. So asthma with rhinitis, inhale corticosteroid plus long, they have cleared up the rhinitis also. And allergic rhinitis reduces the quality of life in asthma. The overall impact of disease with rhinitis and without rhinitis, you can see very well. What are that? How will you diagnose allergies? So it's very simple. Allergic diagnosis can be, so why it is important to know, why we should know that what exactly is the allergy. One, you can do avoidance, and second, nowadays the era of um, uh, they don't want to suffer, so we have immunotherapy which is available in India. I do allergic immunotherapy for this patient. So it is very very important to know as a first step, because we have to prove the patient that your child is suffering because of this allergy. It's important to give them diagnosis of allergens which he is suffering from. And of course immunotherapy is very important. So it's not like every patient I give immunotherapy. Very few selected patients I ask them for immunotherapy, avoidance and symptomatic management. So which test to, there are so many packages in the market present. Don't do any RAS test which costs almost 3,000 3,500 rupees. It's a waste of test. Don't do that. So only two tests, one is skin prick test and another test is immunocap test, that is serum specific IG test, but it's very expensive. It costs to 10,000 to 15,000. In SRCC I do skin prick test which costs you only 4,000 rupees, and which is very very world renowned test. If you see all positional papers from World Allergy Organization, Australian, American Academy of, as well as European Academy, all they mention the skin prick test is the first choice. So any child more than 2 years of age, we can do allergy skin test. Skin prick test actually is the better because it measures the reactivity of the mast cell bound to Ig. And the specific Ig test in blood is, it tests the in vitro testing does not measure the bound Ig, but it measures the circulating Ig. That is very very important. So how do we do the skin prick test? This is the method we do skin prick test, and results are available immediately, less expensive, because I know which test to be done, so no need to do almost 80, 100 tests on a child. Just 15 to 20 is more than enough, which is very prevalent in Mumbai. And of course, it's less cumbersome. Only thing is we have to prick. But now we have the Lancet, which is made from exported from Germany. Hardly any pain for the child. So how do you manage? So it's not just respiratory. Managing respiratory allergies required parent pay. It's not just giving nasal spray and your work is done, or just avoid this and finish. You have to educate every time when they come to. You have to educate about allergen. You have to educate about irritant avoidance. You have to give the pharmacotherapy. You need to reduce the dose. Your dose. You have to increase the dose, and of course monitoring, follow up. Not the only allergic rhinitis perspective, but the asthma perspective. And of course the immunotherapy, which is specialist prescription, can be given. So to achieve the goal, you have to maintain the good clinical control. We need to tell them that this is the treatment. So you have to education. It's a long term therapy, and sometimes you have to give the um, pharmacotherapy in other perspective. So what is the role of antihistaminic? Please do not use first generation antihistaminic like CPM and phenylephrine combination. They are absolute now. They should not be used. If you want to use second generation, not less than 6 months. So any child coming to you with cold, rhinorrhea, do not give any medication less than 6 months of age. Please do not give any medication for cold. Let clean the, just put the spray as much as possible to the child. You can use that simple saline spray, 2 to 3 sprays, because if you give that the first generation, there will be impaired cognitive function, and for that period of time child sleep, but after that it gets irritated because of anticholinergic side effect. So second generation after 6 months and above. So dose is just 2.5 ml, either cetirizine or levocetirizine. Fexofenadine is not a good drug for allergic rhinitis. It is a good drug for um, urticaria, but not for allergic rhinitis per se in less than 2 years of age. And second generation has got some anti-inflammatory effect once a day due to long half-life, and it has got long-term safety. That's why please use second generation oral antihistaminic. They're safe and above 6 months of age, and they are very good for the symptom control, not only for nose, but they can control your ocular symptoms also. Nasal decongestant, please no, never use. The most effective treatment for any allergic rhinitis, whether it is a sneezer type of allergic rhinitis, it could be a blocker type of allergic rhinitis, or it could be a runner type of, or it could be combined. In that situation, the only effective treatment is intranasal corticosteroid. So what is the dose? It's present there. So mometasone, we have fluticasone furoate, we have fluticasone propionate, but furoate is better used because it can be used more than 2 years of age. Propionate cannot be used less than 4 years of age. So furoate, we have Allegra nasal spray, which is the brand. I'm just telling you for your purpose. I'm not promoting any company. Or we have Flutivate, another brand, Flutiflow FT, as well as we have fluticasone propionate more than 4 years, that is Avamis. I'm just giving you trade name so that you can start using for them. And this is just keep the chart. If you are suspecting allergic rhinitis, please start prescribe them. If they are feeling better, for betterment you can send it to us in SRCC. We can give good. So how to use correct method? So this is the correct method for use of nasal spray. And of course allergic rhinitis, as I said, you sometimes you have to combine with antihistaminics, you have to combine with the intranasal corticosteroid. You have to educate the parents, and these are the different inhaled corticosteroid doses available. If you see the fluticasone or mometasone, the bioavailability is less than 1%. So don't worry about डॉक्टर ये तो स्टीरॉयड है तो इसका साइड इफेक्ट रहेगा. There is no side effect until unless you use it improper way. So there is no side effect because bioavailability is very, very less. Montelukast is a very favorite and very famous drug nowadays. In last 1 decade, this is the most a famous drug. I could say that in this last decade, I mean, still it is the famous. But please do not use. Better you start directly internal. If you are in doubt, you can take help of specialist, because he can counsel them properly and he can just start nasal steroid. But Montelukast is a good add-on therapy. It's not the first line of therapy. So remember this. This is anti-Ig, nothing but omalizumab. Nowadays, the era of biological. So we have anti-Ig omalizumab present, but we don't use less than, now the FDA has approved for 6 and above, but we don't use routinely. Better than that, I use immunotherapy, because anti-Ig omalizumab is expensive, but some patient with urticaria, they are very useful, like chronic urticaria. I use them very frequently. So I have 4 or 5 patients who are on anti-Ig omalizumab. It costs around 14,000 per month injection. So one injection per month you take for minimum 1 year of 1 year. And of course, sublingual immunotherapy, that is the specialist domain. If you see local reaction, and that is the reason the sublingual immunotherapy has become very famous, and it is very, very safe in children about 3 years and onward. And as compared to your skid, as compared to your skid, compliance is big concern in India, because sleet is test where it is they will take it for 6 months, and afterward they don't come to you, because it doesn't cost too much. It just costs 1,500 to 2,000, depend on allergen which we are prescribing. But after 6 months or so, if patient is better, they start their compliance goes down, and then again when this the problem occurs, then again they start coming to you. So that is very, very important in India. But it is a treatment of choice, and it is the only treatment which can give cure to a patient. But only thing is, it's indicated in moderate to severe. Even mild to moderate, we don't give patients allergy immunotherapy. And of course, mild to moderate person asthma. If it is severe asthma, it is not. It is a contraindication. So each visit we assess the patient improvement in symptoms of allergic rhinitis, what drug to be stopped, what symptom. So previously, suppose somebody has nasal blockage or stuffiness, and now he's having running nose, the treatment plan changes. So there was MCQ in this session I kept, but I don't think I would be able to do it. So, but I'll just skip that MCQ one, which is the most common immunological brain cell in allergic orchestra. The answer is 2, T cells, as I told you. Which is the gold standard test for allergy diagnosis is 3, that is skin prick test, which is not allergen from the list given below, is nothing but automobile exhaust. And of course, the last following are the treatment option of allergic rhinitis except. So all are except decongestant. So, and the last question, mechanism action of immunotherapy is nothing but, as I told you, it is Th1 response. So in immunotherapy, we change the response from Th1 to, it's like a vaccine, like what vaccine, like corona vaccine is going to come. So all vaccine works that way. Similar way, it's nothing but allergy vaccine. So previously it used to call as allergy shots, but nowadays we are using more of sublingual immunotherapy. Thank you very much for patient listening.
Sir, excuse me, can you show the slide of the nasal sprays?
Yes, yes, of course.
Please, sir, please. Thank you, sir.
Definitely, I'll show you.
Yeah, next. Yeah, previous to that.
This one?
Sir, we should got all nasal sprays with the age.
Okay,
Yeah.
definitely.
With the age.
Yeah, this one?
This one, sir. Thank you, sir.
Oh, yeah. So you can have this slide.
Sir, what is this you just said about allergic rhinitis? Just want to ask you. Mecos syndrome, sir. Mecasia syndrome.
Malaysia.
What is this syndrome, sir?
So nothing but so it's nothing but we have arachnoid folds here in your it's larynx. We have larynx here, then we have vocal cords, and then you have trachea. So this larynx get floppy, it becomes floppy. And children, most of the babies, they present with stridor like presentation early age. So they present with stridor like so this is called as softness in larynx, and that is called as Malaysia. So if softness is in larynx, so instead of getting open, it gets closed when you are breathing in. So when a child is breathe in, that time it should get open, but because arytenoid folds are floppy, they get closed, and that is called as laryngomalacia. And similar way, trachea, if softens, there is no tracheal cartilage, then it also causes floppiness, and because of that, trachea gets closed, and that is called as Malaysia syndrome. So laryngomalacia, tracheomalacia, that's why I said it's a Malaysia syndrome.
So how we treat it? Is it steroids we give immediately?
No. So this is a long term. So we need to diagnose. So suppose somebody present to you like in a stridor in an early age, like after birth, within 2 to 3 days or within first 2 weeks, and his stridor is or the sound is there while feeding, and because of this, if child is not feeding well, is having severe distress, he is failure to thrive, cyanotic spell, or something like child is becoming bluish. In that situation, we do bronchoscopy. So I do bronchoscopy and find out how severe is the and what exactly is the problem, whether just a Malaysia or something else. Suppose it's a laryngomalacia or tracheomalacia, then if it is severe laryngomalacia, then we treat with supraglottoplasty. That's a ENT surgery, very commonly done nowadays. So that
But the sir,
they just tie the yes.
you said it is creates grunting like sound. You said the sound.
No, it's not grunting, it's a stridor. So I will show you the different sounds. So the stridor is nothing but inspiratory. So it's like this, like kabutar gutar gu karta hai na, kabutar.
Yes, sir.
Like this. So it's an inspiratory sound. Then there is another sound called as wheezing. So wheezing में ऐसे आता है.
Yes, sir.
This is wheezing. Yes, that you can hear with the stethoscope if it is minimal. Then there is one sound called grunting. So grunting में क्या होता है ना? Grunting में you have fluid filled in the your alveolus. तो उसकी वजह से वो close बराबर से नहीं हो रहा. तो उसमें होता है grunting like this. So it is nothing but expiration against the closed glottis. You understand? Okay. So that is grunting. Grunting comes when there is a pneumonia. Yeah. Okay. So it's a totally different entity. So that is pneumonia.
Sir, please show those 5 quiz slides.
Thank you so much, sir.
Quiz slides. One question, sir. Sir, long-term use of steroids, sir, in the nasals, does it cause any fungal infection or any atrophy?
Till date, I must have used more than 1,000, not a single patient. But yes, if you are not using properly, if your direction is like this, then definitely possible. But till date, I have not seen a single patient. But there are reports in literature, 1 or 2, not too many. So it's very safe. More than 2 years, it's very safe.
Thank you, Dr. Sagar. I just like to let the
sir, please show those quiz slides.
Please put your questions in the chat box and do not talk just like that. Because if many people talk, Dr. Sagar won't be able to hear, and we have a lot of other questions. So if you just let me know, I will let him know your questions, and we'll get all your questions answered. We have a couple of questions, Dr. Sagar. One is, what are the causes of urticaria other than allergy in children?
Pardon me?
What are the causes of urticaria other than allergy in children?
Yeah, so in children, if it is acute or chronic, depends. So suppose less than 6 weeks, then it is acute urticaria. In acute urticaria, most of the common causes are post-viral. तो वायरल हो जाता है बच्चे को, और उसके बाद किसी को भी, इवन इन एडल्ट्स, पोस्ट वायरल इज द कॉमनेस्ट कॉज. सेकेंड इज एनी स्टिंग. सो इट्स नॉट नेसेसरी हनी स्टिंग होना चाहिए या कैस्पिन स्टिंग होना चाहिए. It could be mosquito bite allergy also. It could be a mosquito. So In winter season and in I see a lot of patients with insect bite allergy. It's nothing but papular urticaria. So it's urticaria. So sting. And third is drug allergy. I could see the patients with simple NSAID can cause urticaria like picture. And food allergy, I would say food wise very rarely, but peanut very common I see, and milk is very common in India.
There is another question on top of that. What is the role of Montelukast and how long should it be continued?
In which condition? In allergic rhinitis?
Well, I think they have put it in continuation to the urticaria question.
Okay. So there is very limited role of urticaria, Montelukast in urticaria. As I already mentioned, please keep this in mind that Montelukast is just an add-on treatment. The most important treatment aspect of any urticaria is nothing but your antihistaminic, and you need to find out what exactly is the that patient is suffering from, whether it is a child or adult. So basically, the acute urticaria, what happens? Most of the doctors tend to give medicine only for 3 days. 3 दिन का दिया, 4 दिन का दिया. Do not do that. If you want to give antihistaminic, give it for 5 to 7 days. Do not prescribe the hydroxyquinine, that is the drug name, Atrax or these. So its better choice will be second generation antihistaminics will be the better choice for these patients of urticaria. Montelukast could be add-on treatment, but not for acute urticaria. For acute urticaria, no role of Montelukast, no role of steroids also. So how do we treat? So for treatment for acute urticaria, you just treat with oral antihistaminics, that is H1 blocker as well as H2 blocker for some time, but do not give for 2 or 3 days, minimum 1 week.
Thank you, Dr. Sagar. So a few more questions regarding medication. So one is how long can you use the nasal spray, and when should you taper it and stop? And similarly for your antihistaminics, ideally how long should it be given, and should you taper and stop or directly stop them?
Okay, so this is very important question. So antihistaminics, the nasal spray. First question, the nasal steroid should be minimally given for minimum for 3 months, not less than that, because the effect starts only after 3 weeks. So you cannot give it for 2 weeks. I see the prescription giving for 2 weeks, 1 week, 4 weeks. It doesn't matter. It doesn't have any role for short term. It has to be given for minimum 3 months. And after that, you see what exactly is the situation of that patient, and then you can taper down whether it is a child, adolescent, or adult. But most important thing is, before tapering down, you should know the what allergen he is suffering from. If he is allergic, he should be properly diagnosed what allergies he is suffering from, because then only you can taper down the medication, and we can tell them how to control the allergies. So that is one. Second, the role of antihistaminic for any allergic diseases is only for that particular time. So whenever there is an acute exacerbation of allergic rhinitis, suppose somebody is on nasal spray, and suppose suddenly thoda sa weather change ho gaya, or something like he has gone to some other place, or some allergen exposure, then in that situation that child may suffer a little bit in that period. During that acute exacerbation of allergic rhinitis, you can use antihistaminic for say 5 to 10 days, something like that. Just use whenever it is required, but sometimes you can use for prolonged period of time also.
Thank you, Dr. Sagar. Dr. Vinita Shetty has raised her hand. You can unmute and ask your question.
Yeah, sir. Actually, my son, he has suffered from recurrent urticaria. So he was treated with antihistaminic 7 days. Then the doctor put him on Montelukast. We continued it for 6 months actually. So 6 months he was symptom free. And as soon as he stopped, again he started with the urticaria thing again and again.
Correct. So we need to find out what are the triggers for his urticaria. So this comes into not into category of acute urticaria or recurrent urticaria. It is chronic urticaria. because almost more than 6 weeks. Okay. So children who are suffering from chronic urticaria, or anybody who is suffering from chronic urticaria, could be a physiological, or it could be a autoimmune, or it could be a idiopathic. So most of the time it is idiopathic. So you need to find out whether he's having something like thyroid issues or something like that. And trigger like physiological, it could be because of cholinergic, thoda sa thandi mein excuse me, like in air condition, or whether he goes to the sun, whether he's getting that. So we need to find out that triggers, madam. So and if it is everything is negative, like your ESR is normal, so you have removed the autoimmune type also, then in that situation, what you can do is you can definitely give the antihistaminic for prolonged period of time, like not just 6 months, you can give it for 1 year also. Sometimes I need to give, but the dosage has to be calculated according how he is suffering. So there is a different scoring system for urticaria. So accordingly we started reducing the doses, or sometimes we need to increase the doses.
Thank you, Dr. Sagar. Another question is the role of immunotherapy, which you spoke about, and at what age can it be started, and what are the IgE levels when you started?
So immunotherapy per se, you have to start, we can start sublingual immunotherapy in more than 3 years of age. That is recommended all over the world. And we have to give it for minimum 3 years, because we need to give in concentration form. So small concentration, then slowly we increase the concentration, and then until 3 years we give complete 3 years, and then we just stop it. Another thing is so immunotherapy is very safe more than 3 years. Less than that we don't prescribe immunotherapy.
Before I ask more questions, Dr. Sagar, if you can put your last slide, a lot of people are asking for your email ID and numbers. So if you can just put that slide on.
I think I have.
Yeah, you just leave that slide on. Thank you so much. So the next question someone has asked is, what is the role of nifedipine sublingual in urticaria? They've asked
what
sublingual nifedipine in urticaria. That's the question that has been asked.
There is no role of nifedipine in urticaria.
And then role of autohemotherapy in chronic cold urticaria. They've mentioned as autohemotherapy.
No, there is no role of autohemotherapy also.
Okay, and then can you tell us a little bit about desensitization therapy?
So that's what immunotherapy. So that is called as is nothing but immunotherapy in a simple word. So desensitization, it depends on the which allergen he is positive. So he could be. I see patients with a lot of allergen positive, but that doesn't mean you have to treat for everything. If you treat the basic one, which is commonest, and we have to give in smaller concentration. So 0.0001%, then you have to go to 0.2%, then like that. So like in an increasing doses. So that is how you have to reach to the certain amount of dose with which he can live lifelong without any symptoms. So that is called a desensitization. So I see patients with drug allergies also. So there are certain patients who are allergic to acetaminophen, but they are not allergic to the paracetamol. So it comes with the this thing. It comes with the practice. So there are some patients who are allergic to the per se what is that drug, which is aspirin, and they had to take aspirin. So nowadays we see a lot of patients with MISC because of post-COVID children. They are coming to doctors with multi-system inflammatory syndrome due to COVID, and in this patient it's like a Kawasaki disease. In these children, if you start aspirin, some may get allergic reaction, and in those children I do desensitization. I do desensitization with the milk also. So this is called a challenge test. So it has to be in a phase manner. It has to be in a increasing dosing manner.
Thank you, Dr. Sagar. We are running short of time, so we'll take 2 more questions.
Right.
So one is should we be telling all our patients to get a skin prick test with AR with rhinitis, acute rhinitis and things?
Yes, of course. The reason is not because I'm doing allergy skin testing. The reason is because this is the era we have to give proof. You cannot just tell ये मत खाओ, वो मत खाओ, ये मत करो, वो मत करो. We have to give them. It's their they should. Dust से allergy है तो बाहर खेलने मत जाओ. You cannot do that. And of course patients also need something, So like they should have some proof. So it is better to have allergy skin testing done in the children. It is not every 6-month test. You have to do once in a while, once in a 3 years or so, but not everybody. Suppose somebody who is having mild to moderate, not suffering with severe, but of course suppose you have given for 3 months of therapy and again that patient comes to you with severe symptoms or any type of symptom, in that patient you need to, otherwise that patient will run away from you. So it's better to take specific specialty opinion so that that patient will remain to you rather going to other physicians.
Absolutely agree. Every patient wants a diagnosis nowadays. Exactly what are they allergic to, and
Yes.
we as a specialist and with modern medicine, we need to give them that diagnosis at least. And the last question that has been asked is there a role of injection histoglob in adolescent children? I'm not sure what the injection is. But...
Yeah. No, I see a lot of patients coming to me with histoglob injection plus some patient on some syrup histoglob also. So there is nothing like that. There is no medication to change your allergic perspective until unless you have your allergy control energy. So that's what I said. कोरोना में भी पेशेंट कोरोना की वजह से कम और उसकी इम्यूनिटी से ज्यादा मर रहा है. आइदर यू हैव हाइपर इम्यूनिटी और यू हैव लो इम्यूनिटी. So children, they are not suffering. The reason being they don't overreact to any, क्योंकि उनको कोरोना क्या है मालूम ही नहीं है. So similar way, allergic person का अगर immunity over है, hyper है, तो उसको control में लाने के लिए there is no medication. Yes, you can do yoga if you are adolescent. You can do yoga for allergic rhinitis, allergic asthma. Yoga helps a lot because it reduces the inflammation of your airway tract. So it helps. But other than that, there is no medication to reduce the allergic sensitization. And of course, food habits which Indians we have, like vegetarian diet. So low inflammatory diet. I would say low inflammatory diet helps in all the diseases, not only in allergic, all diseases.
Thank you, Dr. Sagar. It was an excellent talk and discussion, and now our time is up. So I thank all our speakers today for a wonderful session, and also thank all the participants. We had at time over almost 120 participants, including on YouTube. So it was a great discussion and lovely lectures by our speakers. I'd like to thank everyone for joining us. I'd also like to once again thank SRCC Children's Hospital for arranging this masterclass, which is very useful for all of us, and especially family physicians, where they can interact with specialists like Dr. Sagar and Dr. Anaita and also get their doubts cleared. Thank you so much. Again, I'd like
to... Sir, one question.
Okay, before last question of the day. All right.
Sir, in chronic urticaria, we are giving newer antihistaminic, levocetirizine, cetirizine. But if they are not controlled, we have to add some for H1 or H2 blocker.
No,
in
sir.
Huh?
Yeah, in such situation, what you can do is, sir, you can increase the dose of that antihistamine. You can increase the normal dose to 2 to 3 times more than the normal doses. So, समझो 5 mg का tablet, you can give 5 mg tablet twice a day, thrice a day. You can go to 10 mg also. So, increase the antihistaminic dose. That is the treatment.
No need to add another.
No, you can add another antihistaminic, but again, what you are doing is you are giving antihistaminic. दो अलग देने से अच्छा उसका ही dose बढ़ाओ.
अच्छा. But sometimes we combined levocetirizine with nighttime AV or Atarax to control.
You can do that, sir. But suppose somebody is driver or somebody is server.
No, that antihistamine is nighttime only.
Correct, but उसका effect 24 hours रहता है.
हाँ रहता है effect, पर सर control आता है जल्दी.
नहीं आता है ना, लेकिन उसका साइड इफेक्ट भी आता है, इसलिए तो
साइड इफेक्ट है.
तो इसके लिए
we give in long term. But suppose if we combined giving AV half night time, giving Atarax 5 milligram or 10 milligram.
Right. आप दे सकते हैं, but see व्हाट आई एम सेइंग इज कि आप लेवोसिट्रिजन का भी इफेक्ट आएगा, लेकिन आपको उसका डोज बढ़ाना पड़ेगा। तो अगर आप लोग एक टैबलेट दे रहे, समझो एलेग्रा 120 दे रहे आप, तो उसको 2 टैबलेट्स दे दो, 180 का टैबलेट दे दो। समझो 180 का टैबलेट मॉर्निंग इवनिंग दे रहे, तो उसकी जगह पे 1.5 टैबलेट करो। यू कैन इंक्रीज द डोज बाय 4 टाइम्स।
सर अभी नया जो आया है लियोसिट्राजिन का आगे का
बिलास्टिन।
What is your opinion regarding?
It's a good drug.
What is the dose, sir?
So it's
it is a 20 milligram.
20 milligram. So it's a in children more than 20 kg you can give more than 6 years. Less than 6 years you should not give. 20 milligram is the dose for everybody. More than that they have not studied. So it could be add-on treatment. ये आप add करो rather than I will. ये अच्छा रहेगा.
Thank you, sir. Thank you. It was a very learned lecture, sir. Thank you.
Thank you, Dr. Sagar.
और नया साल मुबारक हो, sir.
Sir, sorry to all the participants, but we are over time. We can't go above 5:30. I know you all still have a lot of questions. You all can send your questions to our SRCC team, and we'll get all our experts to send you the replies. So don't worry about that. I understand there's a lot of questions, and we are limited.
Thank you, sir.
Dr. Sagar. Thank you, Dr.
Thank you, Sagar.
Thank you, everyone, for attending, and I'd like to thank the SRCC team and the Masterclass team again. And we'll give you information regarding the future masterclasses soon. Thank you so much, everyone, for joining in. Thank you for a wonderful session.
Thanks a lot.